they had to say, start coming in. Start coming in. Yeah, I told them. People are not asking questions and they are not coming on this. Where are the questions? The answer to those questions. This is the one will be now, right?
Yes. So
This
you
one
can
I'll-
hold on to this. Keep it in this way, because if you tilt it,
Yeah, understood.
you'll split
No,
the
we'll
screen.
keep it that way. So has somebody announced it outside? I think for to be on time, we start. Welcome post lunch. Gets a little slow because of hyperglycemia, too much glucose to the through the blood-brain barrier. But we start, this session now, starting with a keynote lecture and few other topics. Very interesting. This afternoon is led by the topic of dysrhythmia in 2019, from Hitch bundle pacing to culprit ablation in ventricular arrhythmia. As you know, lot being happening, just like interventional cardiology and the electrophysiology also. And we have a great speaker for you today, Dr. Kalaram Shivkumar. He is the director at UCLA Cardiac Arrhythmia Center, professor of medicine and radiology, UCLA Medical Center in Santa Monica, California. So he, after receiving his degree from India, went to UCLA in 2002, and since then had been there in cardiac arrhythmia as a director. His field of specialization is interventional cardiac electrophysiology, and he has a group of UCLA that is involved in developing innovative technique for the new pharmacological management of cardiac arrhythmia. Very great, very good speaker, great publications, and member of various societies and on editorial board. We are very pleased to have Shiv Kumar to join our this meeting first time. And Shiv Kumar, he took the flight. Now point is he has other commitment. So after his presentation, make your questions ready, send it to me, or otherwise you speak, and he'll answer the question, then we'll leave. You will not be able to participate in our panel discussion. All right, Shiv Kumar.
Thank you so much. Dr. Sharma and the team here, thank you so much for this kind invitation. Of course, we've been big fans of work from Mount Sinai, and you'll see that I'm going to reference that in my presentation here today. It's an iconic medical school, and every time I come to New York to your institution, I'm very impressed and how steeped in history it is. So this is the first sort of my dedication to my team. This is our mission statement. And you'll see that in this slide, I actually have two bookends. One is we do complex interventions in the human heart. And the other extreme, you see that it's bookended by basic science. These are all my colleagues, physicians, physician scientists, clinicians who do the work. And it's a great privilege for me to be a part of that team. And I'd also like to have a brief shout out for some of the, our funding sources. So bulk of our research, of course, comes from tax dollars, as you can see. This is, in this presentation, you'll see some of your tax dollars at work. So how, dramatic is this field? The biggest challenge in mission in cardiology is the fact that 34 people die every minute in this world because of cardiovascular problems, of which 22 people die suddenly. So it is staggering. So when you think of this number, it's 12 million deaths per year globally. And just think about it, right? We had lunch and we came back. And in that 1 hour, thousands of people have died. So, and the challenge of sudden death is also shown in this slide very beautifully, because we spend most of our time as cardiologists, people in this audience, we're taking care of people with severe heart disease, depressed ventricular function. And as a slice of patients in that group, there is about a quarter of them who are going to die suddenly. But when you look at the risk of sudden death, the actual number of people who are dying suddenly, that is shown in this shaded part of the circle. And it actually involves a lot of people who have minimal heart disease and some people who have no heart disease. So that is a challenge. And why do they die? They die because of this arrhythmia. They die because of VTVF. And we now know that one big driver of VTVF is changes in the myocardium, especially changes in repolarization in neurotransmitters. And this, of course, is a big focus of science. And it's also the big focus of interventions, electrophysiologic interventions we use in the heart to prevent sudden death. So diving into this topic, I thought we'll first talk about catheter ablation of VT as a sort of a starting point, and then we'll end up with device therapy. So let's take a patient who you're likely to see later today in your clinic or tomorrow. 52-year-old female, monomorphic PVCs, cardiomyopathy, but no evidence of a scar on an MRI. So when you see this patient, when you see a patient who has PVCs and has a low EF, we now know that this is a reversible cause of cardiomyopathy. You don't have to put them on ACE inhibitors and beta blockers for life. You can actually ablate and treat them. And so this is the kind of the pathway of management that we recently put together in a review article in the New England Journal. So when you have patients who have PVCs or structurally normal heart when they have VTs, you can actually place a catheter in their heart, and right this minute there's a case going on. I just talked to your EP team over here who are good friends of ours. So this is happening this minute right here in this hospital. So we can actually map and ablate these PVCs. And these areas, based on looking at the surface ECG, we can precisely localize where these arrhythmias come from. And using some of the most sophisticated interventional techniques, we can map and ablate these locations. And this has a huge impact, and it's had a huge impact in clinical practice. The next aspect of practice is also that no matter where a PVC comes from in the heart, we are developing more and more tools to get there. Here's an example of the fact that we map all within the coronary arteries and veins. And in one of my responsibilities at UCLA is I get to oversee and interact with the cath group and the cath program. So when you talk to the interventionalists, and you're going to hear from the talented interventionalists over here that they do a lot of work on chronic total occlusion and so forth. And so we were inspired by that work, and we actually interacted with our neuro interventional colleagues. And nowadays, when you actually have VTs that come from within the myocardial wall, so this is a culprit over here, we can actually place wires within the perforating coronary arterial vessels. and you can deliver a small coil and embolize that branch. So this is kind of a precise ablation, which is guided by an electrical recording from within the myocardial wall. So this is intracoronary arterial embolization to ablate VT. But then, what do you do if your VT actually comes from an area where there is no coronary artery or vein? And that's the point where we actually use the Stingray system, which is a chronic total occlusion system that interventional cardiologists use for opening up chronic total occlusions. And so you can actually place a wire within the coronary artery, dissect out of the vessel, and enter the myocardial wall. And in this case, this is a close-up showing you how the wire comes through this specially designed balloon. It perforates outside the coronary artery here, and it gets into the myocardial wall, and you can get a recording from that, and you can actually ablate that region of the heart. So catheter ablation is getting to be very sophisticated, and there is a sort of a synergy and a blending of two fields, if you will, because where does interventional cardiology end and where EP begins? It's all one interventional field. And of course, in very rare cases, if this doesn't work, we actually do intraoperative mapping and ablation. So intraoperative mapping is making a comeback. Now, people with structural heart disease are a much bigger challenge in the world of EP and in cardiology. And these patients, of course, require very special care and very aggressive care. So now let me show you a patient here. This is a 56-year-old male, non-ischemic cardiomyopathy, EF of 30, presence in VT storm, incessant VT. And this is not an uncommon referral that complex EP programs get at places like Mount Sinai and at UCLA. And so this patient's battery was dead because the patient got so many shocks and is now getting external shocks. So these patients obviously are in a state of almost PTSD because of the extreme shocks that they've received. And of course, how do you manage these patients? So it's worth spending a second talking about what drives arrhythmias. Here is a confocal image of the heart showing a myocardial infarct and areas of viable myocardium that is within the scar. And these areas of abnormal electrical propagation interact with nerves shown over here, which is a neuronal stain of the heart. And one of the discoveries we made is the heart is densely innervated. So this interplay of structure and function is what creates the circuits for ventricular tachycardia, which of course in an EP lab, you can place catheters and map out the areas that are controlling these arrhythmias. And it's not only that, you can actually display where there is a scar and which area is normal using computer mapping systems shown over here. So this is a color 3D display of the location of the scar and normal myocardium. And these areas of abnormal electrical propagation shown in this panel is where the electrical impulses sort of meander through and complete a circuit of VT, which is shown in this panel. Now, the big advance in the field of VT ablation is the patient doesn't have to stay in VT for you to ablate VT. You can actually ablate that when the heart is in normal sinus rhythm. So during sinus rhythm, if you carefully place catheters inside the heart and you look for areas of abnormal electrical activation shown over here, these are the areas which can actually sustain or are responsible for slow conduction, which is the abnormal electrical pathway. And these areas can be identified in sinus rhythm, and you can ablate them because these are the sort of the abnormal electrical pathways through which impulses propagate, responsible, which cause VT. And of course, during VT, if the blood pressure is stable enough, you can actually map and terminate VT. But if a patient has hemodynamically unstable VT, that's not a problem. Map in sinus rhythm, get rid of all these late potentials, and the patient becomes non-inducible, and you can control VTs. Now, VT ablation has had a huge positive impact on patient care. And as it turns out, this is, if you look at the literature in the past 15 years, all the top AP academic programs and large clinical programs in this country have set up very specialized programs to manage VT, and mainly because it is a life-saving intervention. So multiple innovations have occurred over the years. This is epicardial mapping and ablation, Mount Sinai is a very famous place for cardiac imaging. And one area of imaging is nowadays, if patients have pacemakers or defibrillators, we still can get an MRI in them safely. And not just get an MRI, we can actually see the heart. As you can see in the panel on the left, there is an artifact because of the implanted device, but you can make these artifacts go away by using a special technique, which is called wideband MRI. And of course, this is something that has had another major positive impact in the field because it goes beyond catheter ablation, right? So if you have a patient who's you're evaluating for any heart disease, you can now get a very good MRI of their heart, and you won't have a problem of interference from the implanted device and these artifacts. Now, this is a slide worth pausing for a second, and what it shows is this is the first large multi-center database, the IBTCC database that was put together. It has data from all the top centers in the world that do VT ablation, and we approached all these sites to actually collate this data. And for the first time in over 2,000 patients, we were amazed by the impact of VT on mortality. So patients in whom you couldn't control the VT, the mortality was awful. It's almost like some cancers. So there's a 30% 1 year mortality, per year mortality, if someone has sustained VT in the presence of structural heart disease. Therefore, VT ablation is life-saving. And the curve over here is these are the patients whose VT recurrence was prevented by catheter ablation. And you can see that this has had a dramatic impact on mortality. And you can see multiple groups contributed to this. This panel in the middle over here, this is Jacob Korath, Vivek Reddy, and Srini Dukipati from right here in Mount Sinai. So we are all very passionate about this procedure because it works in patients with ischemic cardiomyopathy, irrespective of your EF. Look at that. These are patients with very low EFs. Dramatic difference. What about non-ischemics? Doesn't matter whether your EF is more than 30 or less than 30. In fact, sicker the patient, the benefit is even greater. Doesn't matter what is your NYHA class, 1, 2, 3, or 4. No difference whatsoever. Every single group benefits. So VT should be sought and controlled. And you simply cannot ignore VT because it has a powerful impact on the patient's outcome and mortality. And many of these patients actually have reasonably good EF, so there's no reason why they should be on poisonous antiarrhythmic drugs or be sent to cardiac transplantation when that heart can continue to work well for them for the next several decades. And when you look at all the published studies in the literature, which I've put together in this table, you'll see that it consistently shows that catheter ablation of VT is life-saving. So it is well worth being very aggressive. It's a long procedure. Don't get me wrong, it's very hard on the teams that do this. These procedures take 4 to 6 hours, but every one of these cases, it's life-saving. So you're going to see a lot more in the next few years, and hopefully in your future meetings at the symposium, you're going to see more papers that are going to come out that's going to further expand and bring this treatment to a greater number of patients. Currently, we are just operating on the sickest of the sick patients, and a lot of patients are being left untreated. And with the improvements in catheter technologies and reduction in procedure times, we hope someday, much like angioplasty and so forth, we'll be able to move this treatment and expand it to a larger group of patients. Now, moving to the next component of this, again, point to remember, 30% 1 year mortality or need for transplant if you have sustained VT or episodes of VT. So VT has to be controlled. So what about extremely sick patients? Patients who have had previous cardiac surgery, patients who are so sick that they're in cardiogenic shock when they're transferred in. No worries. These patients can also be mapped and ablated, and this is a multi-center experience which was collated from multiple centers around the world, including UCLA and Mount Sinai. We can put in assist devices, impeller devices during catheter ablation. In patients who have previous cardiac surgery, we actually can do hybrid procedures in the cath lab. So this is data that a series of papers that came out of our group, and the Brigham and Women's has also published this, where we surgically open the chest in the EP lab, and you can map and ablate. Therefore, previous cardiac surgery doesn't prevent or preclude catheter ablation because of the fact that there are adhesions in the chest and the EP electrical circuits may be on the outside of the heart. And you also notice that in this slide, we've put in patients who have VADs. So transplant cardiologists, just because they have a VAD, doesn't always fix the problem, because if people have VTs with a VAD in place, that really depresses their cardiac output. And so this is another ever-expanding need for catheter ablation in patients who already have ventricular assist devices. So what about patients, after doing everything with catheter ablation? We've done everything, intramural mapping, and they still have VT. All hope is not lost yet. So if you have extremely refractory VT that cannot be controlled with catheter-based techniques, start thinking differently. Think one level above. Go beyond the heart. So this is another major thrust, and in the past decade, we started doing this first at UCLA, but now many other centers have replicated this experience, where we actually work with our thoracic surgeons, and we surgically, using video-assisted thoracic surgery, we surgically remove half the stellate ganglion all the way down to T4. So you cut the sympathetic chain on both sides, and now this is history repeats itself. 100 years ago, this was the procedure that was used for angina before we knew there was something called cardiac catheterization, long before we were able to do bypass and cardiac surgery and angioplasty. So this is how angina was controlled, and now it's come back to control VTVF. So cardiac sympathectomy is life-saving. And as it turns out, when we look at a international experience, we actually recently published this, and for those of you in the audience, Dr. Fuster gave a very wonderful presentation, a commentary on this paper when it appeared in JACC. And Dr. Fuster, of course, again pointed out that this is life-saving, and you can actually do this procedure without much surgical side effects. Some patients have hemothorax, but the incidence of Horner's and those old complications that you have with sympathectomy is extremely low. So again, reason for a lot of hope and really to bring these treatments to patients. Completing the entire circle, if you will, we now have done cardiac sympathectomy in 3 patients at UCLA with refractory angina who were waiting for a heart transplant because there was nothing that could be revascularized, complex coronary lesions, tiny vessel disease. And 3 patients have been taken off the transplant list after doing cardiac sympathectomy. And these patients are back to a completely normal life and taking very minimal anti-anginals. And these were patients who used to take a bag of medications a day and were still suffering with incapacitating angina. So it's fascinating, and this entire area of neural control is a big area of research focus for us. Now, what about patients who already have severe heart failure and are struggling because of heart failure? And that's one area where electrophysiologists are called to implant defibrillators to prevent VTVF, just to shock them out of VTVF and, of course, hopefully control VT. But what is new in the area of heart failure, and as this audience knows extremely well, with worsening ventricular function, survival comes down, and this is, the typical progress of heart failure. And this has been powerfully impacted by medical therapies, beta blockers, ACE inhibitors, but also by having device therapies. And several years ago, Dr. Brownwall and Dr. Narula had us put together a very interesting atlas of electrophysiology and heart failure. And when we actually collated this data, it's again points out that there are many, many electrical problems, atrial fibrillation, need for ICDs, need for cardiac resynchronization devices in these patients, all of which is life-saving. And in fact, you can see an entire book was edited just to deal with this issue. So what is kind of very fascinating, if you look at the entire heart failure literature from the view and the perspective of an electrophysiologist, this is data that came from a drug that actually didn't work, bisnarenone. But when you looked at survival of these patients in the trial and just looked at their QRS duration, it just shows the wider your QRS, the worse your outcome was. So this sort of planted the seed for really understanding the role of cardiac resynchronization and really trying to understand electrical propagation in the heart. And what the entire field, and as actually is a great example of collaboration between heart failure specialists and electrophysiologists, and doing a series of studies over the past 3 decades, we've actually shown that first and foremost, you can put an ICD to prevent someone from dying suddenly. But then, when patients have a left bundle branch block and left bundle conduction delay, as shown over here, there is a complete reorganization of the ventricle. There are metabolic changes. The heart does not contract effectively, and its pressure volume loop, of course, becomes completely ineffective. So the heart as a pump can be improved by taking someone who has left bundle and putting in a cardiac resynchronization device. And the way this was accomplished was by threading wires into the coronary veins and making the QRS narrow. Now, what has made a sort of interesting comeback in our field is, again, history repeating itself. And this is going back to the work of Tawara, the man who discovered the AV node. And Tawara actually was the first person in the history of cardiology to show that the atria connect to the ventricles, especially the His-Purkinje system. The electrical impulses goes through the AV node, which goes through the central fibrous body of the heart. This was kind of a major advance in the field. And we now know that this, viewed from the left side, the His-Purkinje system, the left bundle, which comes into the LV and activates the greater portion of the LV, can actually be accessed by interventional techniques. So an old idea is making a comeback. And when you look at cardiac activation in normal and in the presence of a left bundle branch conduction delay of various types, it can be proximal, mid, or distal or arborization blocks. In all these conditions, the ineffective contraction of the ventricle can be sort of resynchronized by searching for the His signal, which of course occurs in your surface ECG during the silent portion, the PR interval, right? So if you place a catheter in the heart right here near the membranous septum and you map the patient, you will actually see the His signal shown over here, which is where the His bundle pierces the central fibrous body shown here in yellow. And this region is a region where you can actually place an electrode and pace the heart. And this is a very powerful way of achieving cardiac resynchronization by using the heart's own wiring system. So instead of having to thread a wire into the coronary veins, which goes to the lateral LV wall, you can actually use the freeway of electrical propagation of the heart itself. And to do that, all you have to do is map the location of the His signal and put in a pacing lead in that location. And as it turns out, this is a focus of a lot of work. And looking at these color images over here of normal and left bundle conduction delay, all these areas, all the reds in this image, those regions that are late activated can actually be improved by His bundle pacing. And this His bundle pacing, of course, no matter what the type or the reason for left bundle conduction delay, whether it's SCAR or diffuse cardiomyopathy, it seems to have a beneficial effect. And this is a big area of ongoing prospective trials. And so here's an example of a patient with EF15. All was done was a single lead over here. You can see that this is the His bundle pacing lead, and it dramatically improves EF. So we don't yet have prospective randomized data to say that His bundle pacing is going to replace CRT, but it's a hot topic of investigation. And we as EPs completely love it because it's less hardware in the heart. So I think keep tuned to this. You're going to see a lot more data come out. And I'll also leave you with one last thought. In your clinic, in patients who already have CRT devices, if many of them are having PVCs, that is preventing them from getting full benefits of resynchronization, catheter ablation still has a role. where if you actually ablate those PVCs, and this is data, again, multi-center collaborative data that shows that if you ablate those PVCs, you can actually improve and give them the full benefit of cardiac resynchronization. And I'll finally leave you with the thought that there is a lot of basic science that's ongoing, and we are now really understanding mechanisms of arrhythmias by going back to understand some of the points I made in this talk, such as electrical propagation in the heart and the nervous system of the heart. And this slide has been put up just to show you how delicate and elegant the heart is. There's not a single heart muscle cell that does not have a nerve that runs next to it. And we think that the next generation of interventions, in fact, all of heart failure treatment is actually dealing with what the nervous system does, right? Neuroendocrine activation. So there's going to be an entire generation of procedures that are being designed for the heart, and not just the heart, it goes beyond the heart because the nervous system connects all parts of the body, and we refer to it as the internet of the human body. So you're going to see a lot of therapies that are going to come up that is going to be neuroscience-based therapies, and the heart is no exception to that. So I'll stop here. Thank Professor Sharma, Dr. Narula, and Dr. Kinney, and the faculty here at Mount Sinai, Dr. Fuster, for this honor and the opportunity to talk to all of you. Thank you so much.
Okay, questions? Very exciting presentation and a lot of thought process. What is coming in the future? Superb. Things were so clear, there is no questions?
Very good. Again, thank you so much.
Okay, thank you.
Thank you so much.
Okay. Sorry. Moving along with the second topic of this afternoon is about the hypertension management in 2019, how to define the optimal BP level as per guidelines. Will be given by Dr. Jeffrey Olin. As you know, Dr. Olin is the Director of Vascular Medicine and Vascular Diagnostic Laboratory, Professor of Medicine Cardiology at Mount Sinai. And he has been here for over 10 years and has developed our vascular medicine program. Superb, with the very innovative the techniques and the publications. He's very well, he's on the editorial board of numerous journals and have written COCATs for the vascular medicine, what is required. And of course, this special interest in fibromuscular dysplasia and the coronary dissections or anywhere, the dissection besides specialty in the vascular. He also has now developed a great interest in hypertension and has been on the editorial board and all the guidelines. So we felt that hypertension is a very important topic. Changing with the what should be the guidelines should be, where 130 is too high nowadays, apparently. So he'll update us today on the hypertension management in 2019, that how do we get the optimal BP level as per guidelines and so. All right, Olin? Jeff? Welcome.
Thank you. It's a pleasure to be here. What I tried to do for this presentation is to look in the last 2 years and focus my attention on hypertension papers that have been published in the leading journals, New England Journal, Lancet, JAMA, JACC, Circulation, leading cardiovascular journals, and show you that there is a fair amount of controversy over this whole area of what level do you want to go to. I don't have any conflicts related to this. So in JACC, recently, there was a focused seminar on blood pressure, and if you have not read this paper, I would strongly encourage you to. This is a nice summary of prevention and control of hypertension. Now, in this review paper by Sandra Taylor, she drew this diagram, this figure, in something that we all know, but sometimes lose sight of, that primary hypertension, there's a genetic predisposition. There are a lot of lifestyle changes like high sodium diet, weight gain, excess alcohol. Medications, particularly the nonsteroidal anti-inflammatory drugs, and now that everybody has ADD, the stimulants, and various secondary causes, which I'm not going to talk about, but the most common secondary causes are chronic kidney disease, renal vascular hypertension, and primary aldosteronism. You can see that hypertension is probably the most common cause of stroke and multi-infarct dementia. It's got a whole host of deleterious effects in the heart, which I'm not going to go over, the kidney, and it's also associated with abdominal and thoracic aortic aneurysms, atherosclerotic peripheral artery disease, and aortic dissection. So in 2017, on the left part of this slide, is the American guidelines on prevention, detection, and evaluation of hypertension. And on the right are the European guidelines. And they don't say exactly the same thing. There are a whole host of other guidelines out there, primary care, and every guideline says something different. But the American guidelines really set off a debate about how low you should keep the blood pressure. And I'm going to show you the difference between these two and show you what led to the development of this very low recommendation that everyone should have a blood pressure less than 130/80 and ideally less than 120/80. So here are the European guidelines. Optimal is less than 120/80. Normal is 120 to 129, 80 to 84. Then they have a category of high normal, and then they call hypertension anything over 140 or 90, and then various grades of hypertension. So if you look at this and you compare it to the American guidelines shown here, normal is a systolic blood pressure of less than 120 and less than 80. Elevated is 120 to 129 and less than 80. I don't think there's a lot of us who think of a blood pressure of 125 as being elevated, but this is what the guidelines now say. And then hypertension, stage 1 hypertension, is the systolic pressure of 130 to 139/80 to 89. And there are good data suggesting that the cardiovascular event rate is markedly increased even with blood pressures of 130 to 139. Now, this assumes an average of 2 or more blood pressure readings taken on 2 or more occasions. So as we've done in JACC on a number of guidelines, we do comparison guidelines of the US guidelines versus the European guidelines, and that's what was done in this paper that I'm showing you. We have 2 individuals from the US who are experts in hypertension and one from Europe. And this says that as new trials emerge, the guidelines will be updated. The 2018 ACC-AHA European guideline interprets similar data with a fundamental difference of 2 different blood pressure goals. One is less than 130/80, and one is less than 140/90. Other differences occur in older people. The US guidelines say less than 130/80 in older people as well. And this is supported by the SPRINT elderly data, which is a subset of the SPRINT trial that I'll show you. And then the European guidelines have focused on patient participation and cooperation, and the American guidelines don't say much about that at all. So there are many more similarities than differences. Both guidelines emphasize home blood pressure monitoring. I'll tell you more about that. They both recommend combination medication if you want to lower the blood pressure a fairly large amount. There's more attention to detail on proper blood pressure measurement techniques, and I see all the time blood pressures being monitored improperly. A lot is written about adherence, and I'll come back to that in a minute. Both say that beta blockers should not be the primary drug to treat hypertension. They should be used if there are other indications for beta blockers. and then they both recommend telemonitoring and digital health solutions. There are some differences, as I mentioned, emphasis on the cardiovascular risk assessment through the atherosclerotic cardiovascular risk calculator of greater than 10% 10-year risk. The American guidelines focus more on hypertension. They focus more on ethnic and racial groups. They do have a new definition of hypertension, but they do not discuss isolated systolic hypertension. They recommend a similar systolic blood pressure target for all individuals, and there's no mention of environmental or altitude effects, and these things are mentioned in the European guidelines. So, if you just look at a combination here, this is office, greater than 130/80 is hypertension in the American guidelines. Greater than 140/90 is hypertension in the European guidelines. And there's been a lot written, I don't have time to talk about this, but there's been a lot written about nighttime dipping of blood pressure. And if you have a nighttime blood pressure of greater than 110/65, you have hypertension. And your cardiovascular risk is markedly increased. Those numbers are slightly higher for the European. These are the blood pressure targets we already discussed, and hypertension requiring intervention for anybody above 130/80 if you're in the US, 140/90 if you're in Europe. Now, what about subgroups? In the US, every subgroup has the same recommendations, whereas there are variations in the elderly and diabetics and those with coronary disease, chronic kidney disease, and post-stroke in the European guidelines. So the American guidelines are the easiest to remember and therefore pretty easy to follow. Now, both suggest that home blood pressure monitoring is indicated. I don't agree with this twice in the morning and twice in the evening, as I'll tell you in a minute, but we do a lot of home blood pressure monitoring. Restrict beta blockers to those with comorbidities with an indication for beta blockade, and follow up with detection of adherence. This is a major problem in hypertension. I have no equity in this blood pressure device, but this is one I use. This is the iHealth wireless blood pressure device. There are others out there that are just as good. Once it syncs with your phone, this will say start. You press the button on the phone, and it takes your blood pressure wirelessly. And then it automatically records the blood pressure in your phone without you doing anything. So by clicking on this, you can email your blood pressure readings to your physician, or and it allows patients to really keep track of their blood pressure in a meaningful way. And I give every patient this home blood pressure monitoring sheet. We suggest iHealth, but if they purchase an arm cuff from a pharmacy, Omron is another reputable brand. I focus on arm blood pressure cuffs. Wrist cuffs and finger cuffs are not accurate. They download the iHealth app. We ask them to take their blood pressure 2 times a day for the first 3 weeks so we can see what it's like. And we all ask them to alter the times that they take it so we get a representation of all waking hours. And if they work, we ask them to take it once a day at work and once a day at home. We show them the proper technique. They should be seated. They shouldn't put the blood pressure cuff on over clothes. Their arms should be resting at the level of the heart. They should wait a few minutes and take their blood pressure. If it's above these numbers, they sit there for another minute and take it a second time. And then we either see them or they email us the blood pressures in 3 to 4 weeks. This way, you know what their blood pressure really is. You can also do a 24-hour ambulatory blood pressure monitor. So what have these guidelines done to the number of people with hypertension? So if you look at this, this are the number of U.S. adults with stage 1 hypertension, a systolic blood pressure of 130 to 139, 80 to 89, and or. So overall, about 30% have this. And as we age, the blood pressure goes up, especially the systolic blood pressure. The diastolic blood pressure goes up to about age 55, and then it starts to decline. But you can see here that at age 75, 100% of people are classified as having hypertension according to these guidelines. And those age 65 to 74, 87%. There's no difference in the percentage based on ethnicity or race. Now this is a very interesting study. This took individuals, this is from the Lancet, published this year, took individuals aged 40 to 79 from 123 national health examination surveys in 12 high-income countries. There were a total of 526,336 participants in this. So the sample size was pretty large. And I know this looks like a busy slide, but it really isn't. Let's just say that men and women are equal in all of these parameters, which they are for the most part. So they're looking at prevalence based on country, and the prevalence is pretty much between 30 and in Finland it's 52%. It's 59% in men. Awareness, about 3/4 of the people are aware. There are some countries like Germany and the US where 86% are aware. There are some countries like Ireland and Japan where 50 or 60% of the people are aware. You can look at the number of patients treated, and the number of patients treated is less than the people who are aware almost consistently in every country. And in the US, 86% are aware, 80% are treated, but only 54% are at goal. For an asymptomatic disease that is a major player in cardiovascular events, we don't do very well with keeping patients at their goal blood pressure, 54% in women, 49% in men in the US. It's even worse in other countries. In Finland, it's 29% in women, 26% in men. In Japan, it's 29% in women, 24% in men. So this is a treatable disease that for a number of reasons, we have a hard time getting patients at their goal blood pressure. This, when blood pressure was defined as greater than 140/90, about 72 million Americans had hypertension. Now that blood pressure is defined as greater than 130/80, 103 million Americans have hypertension. But look at this, despite the fact that there's a change of 31 million people with hypertension, only 4.2 had additional pharmacological therapy added. In other words, there's poor uptake on these guidelines. Now, this was just recently published. This is 1.3 million adults from the Kaiser Permanente system. And I show this because it really puts into perspective, like, just by changing what the goal is, it changes the number of people with normal blood pressure. Here, with a goal of 140/90, 81% of this 1.3 million people have normal blood pressure. Here, with a goal of 130/80, only 56% have normal blood pressure. So by lowering the goal, we markedly increase the number of people who are classified as having hypertension. And again, this is an age-based thing using 140/90, about 28% will have it in the later years. Using 130, close to 50% will have it. So what led to the American guidelines decreasing this to the degree that they have? Well, this is the SPRINT trial, and there's been a lot of controversy about this trial. It was the sample size was large, 9,361 people with a systolic blood pressure of 130 or higher and an increased cardiovascular risk, but no diabetes. So they determined this with the atherosclerotic cardiovascular risk score. And they were randomized to a target blood pressure of less than 120 or less than 140. The composite primary outcome was MI, other coronary syndrome, stroke, heart failure, death from cardiovascular causes. And this is what happened. Those randomized to less than 140, this is what their blood pressure was. It was 134. Those randomized to less than 120, their blood pressure was 121. It didn't get to less than 120 on the average. The trial was stopped early at 3.26 years. And the patients who were randomized to more intensive therapy were on one more blood pressure medication compared to those who weren't. And you can see there's a 25% relative risk reduction in the primary composite endpoint. There was close to a 40% reduction in death from cardiovascular causes, or death from any cause, there's about a 27% reduction. So this played a large role in the lower recommendations for good blood pressure control, remembering that SPRINT excluded diabetics. Every subgroup responded in the SPRINT trial, as you can see here. Age, sex, race, previous cardiovascular disease, there was no difference. So if you have normal blood pressure, you just follow the patient. If you have elevated blood pressure, meaning 120 to 129, you should start the patient on non-pharmacological therapy. I'll talk about that in a second. If they're 130 to 139 or 80 to 89, I'm sorry, can we go back 3 slides? 4 slides? One more back? Okay. You go by atherosclerotic cardiovascular risk factor. If your 10-year risk is greater than 10%, you start them on drugs. If it's not, non-pharmacological therapy. Now, I want to talk to you about 2 fairly common conditions. White coat hypertension, you're all aware of. The blood pressure is high in the office. It's normal at home. You can't just assume the patient has white coat hypertension, as every patient tries to make you assume. So when the blood pressure is high in the office, they say, oh, but my blood pressure is normal every other time. You have to do either ambulatory blood pressure monitoring or home blood pressure monitoring. If their blood pressure is normal at home, they have white coat hypertension and you follow them. If their blood pressure is abnormal, you treat them. But this is often missed. This is called masked hypertension. And this has the highest cardiovascular risk, even more so than sustained hypertension. In this condition, the blood pressure is normal in the office, but it's high at home or with ambulatory blood pressure, and this needs aggressive management. So when they say non-pharmacological interventions, this is what they mean. Everyone in this audience knows this. What you might not know is the degree of effect that you get from these parameters. From exercise, you get about an average of minus 5 millimeters of mercury. The DASH diet, dietary approaches to stop hypertension, a diet rich in fruits, vegetables, grains, low-fat dairy products, reduced content of saturated and total fat, the average reduction in patients who follow this is 11 millimeters of mercury. That's pretty good. Weight loss, 5 millimeters of mercury. Reduction in sodium intake, minus 5 to 6 in some people. Enhanced dietary potassium intake, minus 5 millimeters of mercury. And then moderating alcohol consumption to less than 2 drinks a day for men, less than 1 drink a day for women, about minus 4 millimeters of mercury. Now, the guidelines recommend with a class 1 level of evidence A recommendation that your first line drug should include a thiazide diuretic, a calcium channel blocker, and an ACE or ARB, one of those 4 classes of drugs, not a beta blocker, as some of the earlier things. Now, why is it so many patients have a hard time controlling their blood pressure? As you can see from this slide, it's multifactorial. Some patients don't have health insurance or access to health care. In some patients, the hypertension is not even diagnosed, or the blood pressure is measured improperly, or masked hypertension is not recognized. They may not be educated properly. The healthcare team hasn't participated in shared decision-making. Inadequate lifestyle recommendations and counseling, absence of home or ambulatory blood pressure monitoring, low patient and/or provider awareness of blood pressure target. But this is, in my opinion, the biggest cause, and it's clinician therapeutic inertia. Failure to treat mast hypertension, failure to initiate hypertension treatment when present, and failure to intensify therapy in a treated patient when blood pressure is above goal. These are all methods to assess and improve adherence. And some of these are really not practical for 100 million people, like measuring drug levels in the urine. But I'm not going to go over this table, but basically it involves intensive education by the healthcare provider, providing a drug that you only have to administer once a day with few side effects at the lowest cost, doing home blood pressure monitoring and keeping in touch with the patient about their blood pressure levels, and consolidate their refill schedule so all prescribed medications are refilled at a single pharmacy visit. These things will help. Now, this was just published in JACC. This is a great paper for those of you who have not seen it, because this really tells us what's happening. Therapeutic inertia in cardiovascular disease. Clinical inertia is defined as the failure to initiate or intensify therapy when treatment goals are not met, and is a well-recognized barrier to improving patient care. How many times have you seen a patient come in and either their office or home blood pressures are running, let's say 142 over 87 or something like that, and we just continue to follow them? One key contributor to therapeutic inertia is poor guideline implementation and slow integration of new knowledge into practice. However, even when clinicians are aware of the guidelines, there's still considerable resistance to changing previous practice habits. The pervasiveness of this problem in the prevention of cardiovascular morbidity and mortality and other areas of medicine cannot be overstated. So, this paper, and this is the last study I'm going to show you, this paper just came out in The Lancet. And while this is somewhat impractical in our society, this shows what a comprehensive intervention program can do with blood pressure. This is run by Salim Youssef's group in McMaster. This was called HOPE-4. It's a cluster randomized trial. There were 1,371 participants with new or poorly controlled hypertension from 30 communities in Colombia and Malaysia. And they used an intervention which included treatment of cardiovascular disease risk factors by what they call non-physician health workers, using tablet computer-based simplified management algorithms, counseling programs, free antihypertensive medication and statins. That's never going to happen. But supervised by physicians and supervised by a family member or friend. So the primary outcome was a change in the Framingham risk score, in which the intensively treated patients had a marked decrease in their risk score. So let me just show you. So the control group is in dotted lines. This is systolic blood pressure. At the end of 1 year, those in the intervention group had an 11 millimeter of mercury reduction in their systolic blood pressure. This translates into a marked decrease in cardiovascular events. LDL cholesterol. At 12 months, the LDL cholesterol went from about 130 to 124 in the control group and 106 in the intervention group. And I don't have this here, but there was a marked reduction in the Framingham risk score. So while this may not be practical for our society, it does show that intensive team treatment of cardiovascular risk factors, such as what we have in our prevention center on 85th Street and things like that, really is an effective way to decrease cardiovascular events. So the key points are that the 2017 American Guidelines redefines hypertension as a systolic blood pressure of 130 or more, or a diastolic of 80 or more, and recommends lowering to less than this level. The blood pressure target is supported by SPRINT, which shows lower hypertension-associated morbidity and all-cause mortality with a systolic blood pressure of less than 120 than with the target above 140. However, there are greater electrolyte abnormalities, syncope, acute kidney injury in the lower target group, but if the patients are watched carefully, this can be avoided. The initial assessment should look for other cardiovascular conditions, chronic kidney disease, diabetes, but when determining which blood pressure medication you're going to use. Recommend the lifestyle modifications I discussed. We all know how difficult it is to get patients to follow these. The antihypertensive agent should generally be selected from one of 4 classes: ACE, ARB, calcium channel blocker, usually a dihydropyridine, or thiazide-type diuretic like hydrochlorothiazide or chlorthalidone. And if you want to reduce the blood pressure by greater than 20/10, start them on a combination pill from the beginning. Thank you very much.
Questions now? You want to do it now? Maybe. Any question for Dr. Olin? The blood pressure, I'm sure it's a very controversial subject. Somehow they're not being sent. Yes.
The patients with masked hypertension are the most challenging, especially when occasionally they do syncopize when they're optimally controlled at home. How do you suggest we should approach those patients?
Well, you're absolutely correct. First of all, it's challenging to even make that diagnosis, because what's going to make you have the patient take their blood pressure at home when it's completely normal in the office? And I would say if they have a completely normal blood pressure and their cardiovascular risk profile is not really severe, that would be the patient I would have do either a 24-hour ambulatory or home. Fortunately, this only makes up a small portion of the 103 million people with hypertension. And I mean, the recommendations are that you treat according to their home blood pressure. So I start slowly and I have them constantly measuring their blood pressure as per the instruction sheet I give, and adjust my medications like that. But it's pretty infrequent that you encounter that. Yes, sir.
Hi, wonderful talk.
Thank you.
How do you reconcile the recommendations about sodium restriction with the findings from Salim Yousaf's terrific paper of about 6 or 7 years ago showing a U-shaped mortality and event rate with sodium restriction?
Yeah. Well, first of all, that's a great question. And not only that, but there are studies that show that really only about 50% of people are salt sensitive, and therefore sodium restriction won't do any good in those that are not salt sensitive. I think most African Americans are salt sensitive. They have low renin hypertension. But there are emerging data that sodium is an adverse cardiovascular risk. A high sodium diet has an adverse cardiovascular risk, both on the kidneys, on the heart, and show data that are a little bit different than the paper that you're alluding to. So I think overall, a low to moderate sodium diet is probably healthier than a really high sodium diet for most people.
So therefore, in a nutshell, what we should be targeting, 120 or 80 or
Less than 130 over 80.
130. Okay. Well, you got the punchline. Thank you very much, Jan. Fantastic. Okay, let's last but one of the evening and make sure everybody stays till the end because we have a nice raffle, which one of you to go home with the we a nice iPad. Okay, so now in the transcatheter valvular intervention in 2019, as you probably hear, multiple studies recently coming for aortic as well as mitral, and the talk will be given by Dr. Anpurna Kini. She has multiple titles as shown there, but more importantly, very dynamic, very aggressive, and pushing the field forward. That means clearly that how the growth and the innovations are done as shown earlier by Dr. Shiv Kumar in electrophysiology. Intervention also moving tremendously. So there are a lot of new things are done, new things are introduced, and you need to take them, same like grain of salt, not the true salt, but to see whether they really improve the patient care. So transcatheter intervention that basically replacing many of the surgical procedures is here now. And going forward, you'll be hearing more and more. And Dr. Kini will give us update on those two parts, aortic as well as mitral, that where are we? Should we do all those cases transcatheter or still there is a role of surgical procedures for them? Or I don't know.
Thank you, Dr. Sharma, for the introduction. But I hope there are not many surgeons around here. Okay. So essentially, like he mentioned, there are 4 valves in the heart. And right now, all those 4 valves, which is aortic, mitral, tricuspid, pulmonary, can be placed percutaneously without having a cut open chest. But what I'm going to focus today is aortic valve as well as the mitral valve. What are the intervention we can do percutaneously? Just to give you a little background on aortic valve disease, we all know normal is about 3 to 4 centimeters squared, and severe is less than 1, and the critical is 0.7. So other than congenital, acquired, I think this is where we need to focus because this is what we see, calcific, especially because of hypercholesterolemia as well as calcium. But if you see, what is the incidence? 5%, 10%, and by the age of 90, close to 20% of the patients could have had this disease. And we all know the Braunwald description that once they have symptoms, then their survival is very poor with aortic stenosis. So what has been the guidelines? As per the guidelines, surgery has been the standard of treatment. Why? Patients live longer, feels better, and more important, LV function improvement if there is mild LV dysfunction. So how did the percutaneous come into existence? The father of percutaneous heart valve therapy was Alain Cribier, where he did his first case on April 16, 2002, and subsequently the publication saying that non-surgical implantation of a prosthetic heart valve can be successfully achieved with immediate and mid-term hemodynamic and clinical improvement. This is the first patient that got that valve. So coming to tower, most important because in the past, what used to happen if somebody has aortic stenosis as diagnosed by stethoscope, what people would then send the patient for cardiac cath. But with the advent of percutaneous therapy, things are changing. Diagnosis is made by echocardiography. And then what we need to do is also have what is called as a CT scan, which actually is going to help us to tell us what is a kind of valve sizing and can they have, what's the kind of the route for the placement of the valve. So what is based on imaging on echo, severe AS is here what we have to, you have a mean more than 40 millimeters of mercury. That is why I think you can hear every time you're calling us, referring for patients, we always ask, is there an echo? If not, when you refer a case to us, we will do an echocardiogram. So these are the criteria, which is like you have a mean of 40. That is the criteria for us to say, yes, that this patient will then meet the criteria for aortic valve. Then the second step is that every patient will have what is called as a STS risk calculator based on their age, gender, and various risk factors that they have. This is an online risk calculator. Why this is important? Because this is what the surgeon will depend on. This is how the trials were done, that More than 50, the STS score, that means they are too sick, usually would be a palliative care for this patient. More than 15 were extreme risk, about 20% of the patient. And then high risk, about 10 to 15 would be a STS score, but intermediate risk was 4 to 10, and STS score of less than 3 were low risk patients. Well, how did a tower come into existence? Is we started with extreme risk trials, then we did intermediate and up to the low risk. So these are the trials that I'm going to go over. And there are 2 FDA approved valves. One is the Sapien, other one is the core valve, which is Evolute. These are the various routes that usually a percutaneous valve can be placed, but the most common is femoral, subclavian, and now even transcarotid valves are being done, but these are the most common approaches. So the first trial was a partner cohort B, which was same extreme risk, what I showed you more than 15%, and what it showed that compared to standard therapy, where patients had just medical therapy when the diagnosis of aortic stenosis happened, if they had TAVR, there was a 20% reduction. Subsequently, the core valve did a trial. Since there was a benefit, they did not have the arm of standard therapy. Everybody got the valve, and the FDA approved the valve first 2011 for the Sapien valve, and the core valve 2013 for the patient who are extreme risk cases. Then was a partner cohort A, which was for the intermediate risk. Similarly was for the core valve, which was for the high risk, which showed both surgery as well as TAVR were equal, except in the partner trial, there was a slightly higher incidence of stroke rate with the TAVR compared to SAVR, but subsequent trials did not show that. And then it was approved at 2014. Now, then was the intermediate risk that came, where was partner 2A trial, and the Certavi trial was done for the core valve. Again, SAVR versus TAVR, both were equal. FDA approved for intermediate risk between 2015 and 16. 15 was same for the Sapien, and this was for the core valve. So then what happened is that definitely for extreme risk and high risk, by then there was already TAVR, and this is, I just wanted to show you a case of, that means by then the intermediate risk was already approved. So this is a 74-year-old female, 2016, NYHA class 3. Some risk factors here, if you see, and then was on good medical therapy. Non-obstructive coronary artery disease on her angiogram. This was the echo. You see here significant aortic stenosis with a mean gradient of close to 50 millimeters of mercury. Now, if you see here, STS score was 2.1. So what happens? The surgeons see the patient. At that time, the low-risk trial was ongoing, and the patient got randomized to the TAVR. So what we normally do is get a balloon angioplasty, balloon valvuloplasty first, and this is the core valve. If you see here, always we make sure we are starting at the right position, and this is how we gradually release the valve, and once we know that it's at the right position, then we completely release the valve, and very mild AI. Because there was some AI, we did a post-bar dilation, and this is after that AI is gone. But what you can see is that the coronary arteries, you can still see a good filling from that. So patient did well, went home 48 hours later on clopidogrel only because no aspirin. GI bleed, will discuss this, what should be given to the patients, and has been seen subsequently doing well and only has been on clopidogrel and atorvastatin. In this patient, we continued clopidogrel because there was history of CAD. So if the question comes, okay, you have done the TAVR, and surgery we know has been the gold standard, has been done for many years. So this is a 5-year follow-up. This is the mean gradient in this patient. If you see here, your valve area is about 1.5, which is excellent, much better than the standard surgical valve. So for low risk, more trials have happened. So 2 trials in the US were completed, which was Partner 3 and Evolute, which were presented this year during the ACC, and the other trial was a Notion trial, which actually has been ongoing. If you see here, this is a Notion trial, which was SAVR versus TAVR, about 280 patients. what you see here is for the low risk patient, everything is equal, no significant difference except slightly higher pacemaker rate in this group of patients. And this is the clinical outcome at 5 years. Other than the pacemaker, no difference, TAVR versus SAVR. So why low risk came into existence is having had all the high risk, intermediate risk TAVR having done. So partner 3 study, what was it? Is a low risk patient were randomized to TAVR versus SAVR, but the TAVR had to be done only via the femoral route in this particular case after the heart team discussion. So if you see here, the first trial to show that actually TAVR was superior to surgery. And what was important is that no difference again in any of these outcomes, and the length of stay was significantly lower in the TAVR patients compared to the SAVR group. And one thing was for sure, people who went for a surgery had some higher incidence of AFib. This was the core valve, similar design, TAVR versus SAVR, and then they had a sub-study to check what happened to the leaflet, heart team discussion. It is very intense when these studies are being happening that you have to do echo, CT scan, upload them, then there is a screening committee, and the heart team evaluation happens locally. When everybody has decided that this is the right patient, then only the patient gets randomized to TAVR versus SAVR. A similar outcome, and look at the length of stay. That patients go home less than 3 days compared to surgery, they stay for longer. But as we have shown that always TAVR has slightly higher pacemaker rate compared to surgery. So based on that, this was the New England Journal paper that came out with the simultaneous publication, and this was the New York Times, which said that FDA approved TAVR for low-risk aortic stenosis, and this happened July of 2019, which you probably have heard from us right now, that even the low-risk patients will be getting TAVR. So it is relatively, what are the potential complications of the TAVR, if you think, which is most of them are very rare, but one thing that we have to, everybody gets worried is about stroke and TIA, and of course, valve degeneration. Although I have shown that there is data up to 5 years that valve works well, I'm going to discuss a little bit about valve degeneration. Now, stroke TIA, since these patients are elderly, not the low risk, even the high risk and intermediate risk, when we are going through the aorta, definitely it is atherosclerotic aorta, the risk of stroke is less than 2%, and guess what? Interventionalists, if there is one problem, they'll find a device. If that device does not work, some other device. So these are the various reasons why we can have this. Either it's embolized from this aortic valve or from the arch when we are going through when you are getting the valve across. So these are the devices that were actually tried, but right now Claret Sentinel device is the one that was been FDA approved based on this particular trial. What it showed, those not statistically different, lower stroke in the treatment arm compared to the control arm in that one trial. So every patient will be screened. They need to have a good radial artery so that we can go from the right radial and place this Sentinel device in both the carotids before we do the procedure. And this is just to show SAPIEN versus core valve. They, like any other device, a lot of generations have changed. This is the current generation essentially saying that these valves are better. And the next point is, can this be used in bicuspid aortic stenosis also? What's the difference in bicuspid versus a tricuspid aortic stenosis with early and new generation device? Same, that it can be used in bicuspid valve with a good result, with no difference whether it is bicuspid or whether it is a tricuspid valve. Other than common scenario, which is a rare scenario that we see, but often I would say about 20% of the patients that are referred to us, one is paradoxical, where your EF is low. Other one is low flow, low gradient, where you have a normal EF, but since LV cavity is small, that you have AS, but your gradient is low. So would these patients benefit from TAVR? So there was one trial called as a Topaz-Stavi trial that actually was published in JACC. If you see here, what they did was definite. The mean EF was about 30% and a gradient about 25 or so. And many of these patients did undergo dobutamine stress to see what the gradient was. And this was that beautiful central figure, which is just showing that presence of contractile reserve or no presence of contractile reserve. The original data was that if you go for surgery and you had a presence of contractile reserve, they did better with the mortality benefit. But if they did not have contractile reserve, they did poorly when they went for surgery. But with TAVR, both the arms, with whether they had contractile reserve or no contractile reserve, they did well, essentially saying that TAVR is doable for this kind of patients. This is another one that we are saying that TAVR can be done for valve-in-valve. That means they already have had a prior prosthetic valve. And can you do a TAVR? The prior prosthetic surgical valve, can you do a TAVR in those particular valve, both whether it is SAPIEN or Medtronic core valve, saying that actually TAVR probably was better, and they compared it to native TAVR, saying that yes, it can be done. So this is just another case where I'm showing this is a bioprosthetic AVR, and had a whether it is restenosis or sometimes they always come some AI also. So this is a SAPIEN valve in place. This is the second valve that we are placing. And the SAPIEN one, the one I showed earlier was self-expanding, but this is a balloon expanding valve. So this is the TAVR valve there, and which is with the balloon. Once you expand with the balloon and then you deflate the balloon, you will see that the TAVR valve stays there. So you can now appreciate the original native valve, the bioprosthetic valve, and now the stent frame of the new TAVR valve. So subclinical leaflet thrombosis became a big issue. This is the same concern. Why does it happen? Is it because they are not on anticoagulation, or is it because of some damage we create with the balloon, whether when we are placing the valve, or because of the balloon valvuloplasty we are doing subsequently later to prevent a paravalvular leak? This is the CT scan, what they do. We can be followed up. So you see some leaflet thickening. So essentially, if you see there, what this study showed that came out in the Lancet was anticoagulation will reduce leaflet, but there is studies also shown, which is actually Galileo, that will be, this is presented sometime later this year, saying that patients who, there was no difference, more important also that there was a higher incidence of bleeding in this group of patients, so much so the study had to be halted. So at this time, we just have to carefully monitor these patients. They will get an echo at 1 month, and if there is any change in gradient, means normally the gradient should be less than 10 in any kind of this valve that we have placed. If the gradient is more than 10, we probably will ask them to come earlier than a year. Otherwise, it will be a yearly surveillance where we will do an echo here at Mount Sinai. And also other thing always comes is this TAVR patients do have concomitant coronary artery disease. So what will happen to them? If we see coronary artery disease, should we take care of the coronary artery disease? So this is a CERTAVI trial where you see patients were assigned, if they had TAVR, they were assigned to PCI. If they had SAVR, they were assigned to CABG. There was no difference. So if you are doing TAVR, and if there is significant coronary artery disease, you can take care of the coronary artery disease before the TAVR. So when I'm saying significant, we are talking epicardial vessel of more than 80% lesion. Anything less than 50%, we can leave it alone. This is the publication from our group that came out in JACC last year, that coronary angiography and PCI after TAVR. Why we should pay attention to the coronary artery disease before and take care of them? One, they, of course, during the procedure for about 30-40 seconds, we will have no cardiac output while we pace the patients. But subsequently, engagement of coronary arteries through this nitinol cage is very challenging. So this was the article that we published saying what are the catheter selections for the patients who have had TAVR, and that is also made an app called as TAVR Cathade. So we made some beautiful animations that is showing you how exactly you should be dealing with this catheter placement, that you got to be very cautious how you are entering this TAVR valve and how you're going to engage it through the right diamond to enter into the coronary artery and to do coronary angiography. So that is the core valve. This is the SAPIEN valve. What we also created is an website right now for all the apps that Mount Sinai Cath Lab has made, which I will go over a little bit later. These are all the apps that are available. Anybody wants to, you can download it from the App Store or Google Play. It's all free. So outcomes of Mount Sinai Cath Lab TAVR for 2018, if you see, just 50% of SAPIEN valve and 49% core valve. So if you see here, you'll be asking what kind of sedation, because these patients will be probably asking you these questions, or when they come to see us, is 75% conscious sedation. Anesthesia are involved, but when they are in the room, they just give some sedation, and very rare, 25% will be GA. So if you see, close to 90% is a perc femoral, about 10% cut down, and very rarely we do subclavian. If you see, the TVT registry is a registry of the entire, which ACC maintains it, and our data compared to TVT registry, we definitely have, if you see, it's all comparable. And coming to the choice of TAVR for TAVR versus surgical VAR in AVR patient, I think I've made it very clear that most patient, which is prohibitive surgical risk, high surgical risk, intermediate surgical risk, based on the guidelines, everybody can get TAVR. Only thing low risk on the guideline was supposed to be surgical AVR, but with the recent trial that just came out, even the low risk right now would be TAVR. So the final question would be, this is the projection, what you see here, annual TAVR procedures in USA. The projected will be about 60,000 procedures here, TAVR growth. So the question is, who are the patients should be referred for surgery? So low to intermediate STS risk and extensive coronary artery disease. So like I mentioned, if you think there is a 3-vessel with significant coronary artery disease, those patients definitely should be considered, and probably better that should go for surgery. And bicuspid AV with the low STS risk, because right now bicuspid AV is on the registry and a trial has not been FDA approved yet. Young age with the issue of future valve degeneration, but if you see there's concomitant aortic root dilation and needs aortic root surgery, that patient should go for surgery. And very rare, we will see a case where there's a lot of calcium, especially in the LVOT, there's a risk of rupture when we do this TAVR. And there is a low to intermediate risk patient with a bioprosthetic dysfunction. If you have a 50-year-old with a bioprosthetic valve, maybe you should consider second surgery rather than do TAVR. And very important is adverse anatomy, that you have a low-lying coronary height. Based on the CT scan, which is important, we also will get the height of the coronary artery, that when we do TAVR, there's a risk of occlusion of the left main. If that is something we think is there and the patient is low risk, those patients definitely should go for surgery. And of course, if there's concomitant other valve disease, this kind of with low risk should be considered for surgery. Moving on to mitral clip, that is mitral clip for all functional mitral regurgitation. That is something, let us figure it out. So total patients with mitral regurgitation, about 4.1 million. Eligible for treatment with grade 3+ is about 1.7, and the annual incidence, if you see here, is about 250. But more important is MV surgery, only 30,000 per year. So only 2% treated, so there's a large group of patients who are not being treated, probably need something done to these patients. And we all know how mitral regurgitation works, that mitral regurgitation begets mitral regurgitation in the sense that it increases LV strain, LV dysfunction, more MR, and thus increases mortality. And also, we know that MR and heart failure, there is moderate to severe MR in patients with heart failure. About 40% of the patients do have concomitant mitral regurgitation of some severe degree, and about 5 million patients are there with heart failure in US. So there are two classifications of mitral regurgitation. One is primary. Primary means there is something wrong with the anatomy of the valve, which is usually prolapse. That's all we finally. But then it could be subvalvular apparatus or problem with the papillary muscle. But what we mainly deal with is the leaflet prolapse. And the second one is secondary. Here the LV function will be normal. Secondary, you have LV dilation for whatever reason it is, and that LV dilation give rise to mitral regurgitation, and that is the secondary MR. So what is the guideline right now? Management of mitral regurgitation, if you see here, first you identify, define what is the cause of mitral regurgitation, and assessment has to be done by the imaging, and most of it is echo, which is transthoracic, or TE. But if you go to treatment, if you see here, it is just a teamwork where a lot of people are involved in managing these patients. But essentially what you need to do is make sure that they are on good medical therapy and lifestyle modification for these patients. And here it comes that if the surgeons think the patient is prohibitive risk for surgery, that's the time those patients should be referred for mitral clip. But the key is follow-up. Just because they got mitral clip or just because they got surgery does not mean that they should not continue what is called as guided medical therapy, management of hypertension, AFib, CAD. All these things have to continue. So this is the important thing that you need to know for management of mitral regurgitation. So current therapy is the same, medical therapy. Everybody has to be on medical therapy, especially if it is primary MR. And you have what is called surgery, but what I'll be discussing is maybe less invasive procedure, which will be mitral clip, which is a venous procedure. And you will see this animation right here. It is a large sheath that will be going from the vein, and you do a transeptal procedure. You have to go from the right side to the left side. This is a sheath that will go into the left atrium, and this is, you see the clip. And this clip, the same thing, there are various knobs where you can go anterior, posterior, medial, lateral, and this, like most procedure where interventionalists do it under fluoroscopy, this procedure is guided by the echocardiographer. So you have a TE and echocardiographer with you telling us where to do the transeptal. The key part of the mitral clip procedure is to have the right transeptal so that then your navigation of the whole device and placement of the clip becomes very easy. So if you're not happy, again it can be released and place it in the right place where you know the right part of the leaflet has been clipped so that the mitral regurgitation goes down. So the first trial that was done, randomized other than the non-randomized trial, was Everest 2. Device was to control, same, 2:1, and the patients were followed for 30 days, 6 months, 1 year, up to 5 years. And what it showed, any device that comes out, first and foremost is it safe and effective? So same, definitely it was very safe. Venous procedure, compared to arterial procedure where like TAVR, where we showed there is a risk of stroke and all that's unlikely, but effectiveness is same. The therapy for mitral regurgitation, which is surgery, compared to that was okay. So based on this trial, what happened is there was a New England Journal publication showing that although percutaneous repair was less effective in reducing mitral regurgitation than conventional surgery, was associated with superior safety and similar improvements in clinical outcome that left to the FDA approval for the degenerated or primary MR. Right now, we have the FDA approval only for the primary MR to do the clip. So this is a 79-year-old female who had a EF of 25%. And what happens is, I would say about 15% of the patients would have mixed, where they have a prolapse as well as dilated LV. So this patient actually belonged to that group where she was mixed. So if you see here, severe mitral regurgitation, this is a 2D echo. This will be the 3D, where you can see a nice prolapse also on the 3D echo. But more important, we can do simultaneous measurement of the V waves in this group of patients, and V waves were almost 80 in this patient. So first clip was placed. I'm not sure if you can see it very well here, but at least here you can see that the clip is in position. But then what happened, from 80, it came down to 50. Still you can see prolapse on either side of the clip. And what happens is, once you have released, or before you release, you also have to make sure that the gradient across the mitral valve is not significant. So it should not be more than 7 or 8 millimeters of mercury. So this was low, so we proceeded with the second clip, which was placed. After the second clip placement, came down to like 40, and then we actually went to the third clip. If you can see, you have 1, 2, and a third clip placement here. After that, we brought the V wave down to almost 25 or so, and regurgitation, which is severe, came down to mild. So this is what you will see, how the clips will look like. So the TE probe there, these are the 3 clips. So this is the X-ray, where I think with many people may not be aware of. Everybody knows a pacemaker, a AICD lead, how it looks like. But if you see something like this, it is a mitral clip that we have placed. So this is end result. Case 2 is another patient. If you see, these are the patients who are multiple comorbidities on good medical therapy, which would include Lasix, ACE inhibitor, beta blocker, and then they continue to have heart failure. These are the kind of patients they are referred to us. So if you see here, same big V waves, close to 25 on medical therapy, and nice prolapse. Look at the MR, significant MR. And this is a clip in the 3D, and reduction of mitral regurgitation. You barely see what I say. No RBCs are going back to left ventricle now. Look at your V waves down to 5. This is a single clip there. This is just to show you the end result. Severe MR to mild MR, or probably minimal. So, like I mentioned, how would you do the transeptal procedure, and how to do the clip and transeptal procedure also important if you are doing other mitral percutaneous procedure. We have an app for that. Again, you can check that. It's free to download from the App Store or the Google. This is what we have done. You see the hybrid images, where this is X-ray, this is how the echo will play, and we have various animation to help you how to do the transeptal. Actually, there's a video that will show how a transeptal procedure can be done, step by step. So when actually you're doing a transeptal procedure, like I was showing you, what you need to know is that the height from where you're measuring where transeptal is key. This is how the echocardiographer will tell us, you got to be posterior and high. Your height should be 4 centimeters or above, so that you will then be able to navigate your clip. If you're very low, the clip will be difficult to reach the mitral annulus. You need to be posterior and higher. That is why this is the key I told you is the transeptal procedure. This is the most important trial that was presented last year during a TCT, a randomized trial, whether standard of care versus clip would work for patients with secondary MR. So that was the background, where we know for patients with dilated LV and MR who are in heart failure, that surgery is not the treatment. But more important is guideline directed medical therapy or CRT had to be done on these patients, and despite that, if they had symptoms, they were the one randomized. So it's key that everybody knows that patients with heart failure and mitral regurgitation have to be on full medical therapy, and symptomatic on therapy and have MR. Because what happens, I would say about 60% of this patient, when you give them some kind of therapy, the mitral regurgitation disappears. So if they have symptoms on therapy, they are the one they were randomized to mitral clip along with therapy versus guideline directed medical therapy. So this is how they were randomized, about 300 in each group. And if you see here, most of things in both the arms was equal. But very important is the risk group of this patient: diabetes, hypertension, prior MI, prior cabbage, TIA, and then look at the heart failure. Look at their BNP, 5,000. So they were sick patients when they were randomized. And STS score, I told you just about 8 or so, these were high-risk patients who were then randomized to medical therapy. And CRT, about 1/3 of the patients were on CRT. So the medications that they were used were beta blocker, ACE inhibitor, mineralocorticoids, but more important, diuretics. Everybody had to be on diuretics. So multiple or 1 or 2 of these medications had to be there. And patients were compliant. This is the reason why we are showing this slide, saying that most people were compliant, that there was not that they were started and did not continue on medication. So the clip procedure, if you see, was successful, 97% successful clip. And also, if you see here, more than 95% of the patient had less than 2+ MR when the clip was placed. And the number of clips, if you see, 1 clip, or majority of them got 2 clips. 1 patient got 4 clips. So what was the primary endpoint? All hospitalization for heart failure within 24 months, which was significantly lower, as well as more important is the first time the trial showed that these patients actually had mortality benefit compared to standard therapy, which was just medical therapy here, which was significant. And this death or any kind of heart failure hospitalization also was better when patient got clip compared to just medical therapy. So what they concluded that in patients with heart failure and moderate to severe mitral regurgitation on therapy, mitral clip is safe, reduces hospitalization, improves survival and quality of life. So is first-line therapy to improve prognosis in patients with heart failure secondary to LV dysfunction and secondary MR. Now, going on to that, there is a group of patients who could benefit from not clip, but for whatever reason that they could benefit from valve placement on the mitral area. But who are they? Patients who have calcific mitral annular calcification, which is called native MAC. If they already have a valve, mitral position, or they had a repair with a ring. So this was a trial that was presented in 2017, and subsequently you'll see the results of these patients. So essentially, I think if you think at the valve-in-valve patients, which is previous prosthetic mitral valve, they actually did better compared to valve in MAC versus valve in ring in this group of patients. So if you see the survival, all-cause mortality at 1 year, if you see valve in valve, which is in green, was okay, but the valve in MAC survival was very bad. So essentially we are saying that valve in MAC, which is native calcific mitral annular calcification, is not a good treatment. So just to show you a case, again, 77-year-old lady, multiple comorbidities, who had a 25mm Hancock prosthetic mitral valve, with heart failure, and was not a candidate for surgery. So this is how this is. You see this, the prosthetic valve, and there's a degeneration and some regurgitation in her. So she had a gradient of 19mm of mercury across that valve. So how do we do this procedure? We will do transeptal, and see this stiff wire across, and we'll go into, this is the mitral prosthetic valve that you would see here. So now we are inflating the sapien valve in the mitral area. It was fully inflated. This is how it looks at the end. So the gradient reduced from 19 to 7, and this is the leaflet of the newly placed sapien valve on the mitral area. This is the pre, and now you see the new valve, 3D echo. So essentially what we are saying is that it is a good treatment for patients with valve-in-valve. So just for conclusion of the mitral, that mitral clip results in clinically significant MR reduction, majority of the patient. It is safer than surgery, and mitral clip results in similar patient-centered outcome to surgery, including improvement in heart failure and quality life and reduction in readmission. So it is ideal for poor surgical candidate with appropriate anatomy. So what we request is these patients will be seen here, heart team, which includes an interventional cardiologist and a senior surgeon that will see the patient together. And when we say appropriate anatomy, means these guys need a protocol-driven TE done here so that we know that we can do a nice transeptal, and we need to understand how the mechanism of mitral regurgitation, and is there enough leaflet for us to grasp when we are doing the clip. So that TE is to be essentially done by us here in Mount Sinai. Is now FDA approved for patient with the degenerative etiology. The one co-op trial that I showed you, we still do not have the FDA approval, which should be happening in the next couple of months, which means that patients with secondary MR also could be suitable for mitral clip. TMVR device for native disease have potential, but has a long way to go. But TMVR used for SAPIEN valve has been recently approved by FDA for bioprosthetic mitral valve degeneration. So if this is very important, that if they have a prior mitral bioprosthetic valve and there's a degeneration, then SAPIEN valve has been FDA approved. This is the live cases that we do as much as a teaching institution we are. We have done it for PCI for the last 10 years, and we do structural, which is every other month, second Tuesday at 9 a.m. So most of these are archived. If you go to ccclivecases.org, any of the things that you will have a didactic discussion with a lecture by Dr. Sharma, then we go over the case. So, during your free time, you can watch it, archived cases. They are also available on the YouTube, where you can, learn many of this, at least understand what these procedures are, where the discussions are happening. Now, this, since it is worldwide, so the total page views are over 1 million now. And what we just recently did is all the apps that we are doing. We have a website that we have created, very simple, cardiologyapps.com, and all these apps that we have created can be downloaded for free. Thank you for your attention.
In this field, another very evolving about who should get the surgical consultation or surgical procedures now compared to transcatheter, both mitral and aortic. Even for the mitral, the guidelines still remain that patient has to be on optimal medical therapy before they qualify for the mitral clip procedure. So what is the role of
I think one slide I did not show. For primary, you don't have to be on therapy. I think primary, if the surgeon says patient has a prohibitive risk, they can go directly to clip. But for secondary MR, definitely who are in heart failure with LV dysfunction, we got to make sure that they are on guided medical therapy, which I think all the drugs that I've mentioned, at least 2 of them, they have to be on that, and still on heart failure, and we demonstrate that they have mitral regurgitation, then those patients with suitable anatomy will get clip.
Okay, so looks like we're ready for the last presentation. Thank you very much, Anu. So just hold on another 30, we are on time. We always have been, even our complex cases when we do the June symposium, like 14 cases in a day, or our December now with the structural, we try to finish in time. So with that note, let's go with my presentation of top 10 trials of coronary intervention for 2019. So only for coronary. I would not talk about any of the structurals which have been very well covered or non-interventional topics. So I think it's just taking a little time to, good. No, that's a little wrong. I probably won't be able to talk that. I just gave the slides, maybe that's why it's a little late. So last slide, come back to the first slides. And give us the feedbacks for next year will be about same during that Columbus Day weekend. That Friday will continue this activity. And same pattern of 4 plus, so there and there. Okay, good. All right, we got into, so now I'll present a lot of data and I then summarize in the end what all these interventions, the changes or advances really mean. What happened here? No? Okay. Okay, let's start with the first one. So it means, can I play with this or no?
No, this is to advance, and this is to point.
Point. Ah, that's okay. Good. Good to learn. Let's see now. We go back. Okay. So this, I always start my first slide for the intervention because of Andreas Grundzwig, who did his first angioplasty. We call him father of angioplasty. His dream was the catheter-based percutaneous treatment of vascular disease in alert and awake patient. And of course, ultimate safety. That is, I put it my quotation. And that is where we are now. And the cases, examples which Dr. Keeney showed, that is what happening now, that all the transcatheter cases, they are discharged in 24 hours, just like PCI. So many of the cases now, almost 35% are discharged next day, getting a tower today and going home next day. So purpose of what I'm going to share with you is top 10 trials of coronary intervention of 2019. We still have AHA next month. So particularly the ischemia trial will be very big, but we'll wait for it, and that will become part of my June top 10 advances of coronary intervention. So now, until now, what has been presented with this year's ACC, European Society of Cardiology, and recently Transcatheter Therapeutic, because these trials, which I have included, make sense because we are going to change our practice. So first one is atherectomy studies for calcified lesions. So calcified lesion, basically you can see it's on angiogram, the tram track, you can see the ghost of the vessel. Yeah. Okay, and there is no pointer. We can show it here. Forget that, yeah. So basically, you can see the calcium by angiogram and then by various testings by IVUS as well as OCT. This is the problem because calcium gives trouble for interventionist. Your stent doesn't go, does not expand, and have a lot of complications. So there are a lot of devices which have come, particularly atherectomy, rotational and orbital atherectomies. They have different mechanism of action and takes care of this calcium, basically. And subsequent stenting has shown to be beneficial or good stent apposition. Now, it's used only in about 5-7% of cases. It's still a small number. Calcific lesion, particularly severe, is about 10%. Half of them getting the atherectomy in the United States at present. We actually did the trial, MACE trial, to see what is our pattern of how do we take care of the calcific lesions. These are the none on mild, middle being moderate, and severe on the violet color, showing that only 1/3 of the severe calcified patients getting atherectomy at present. Majority are just getting without atherectomy. So what were the results? Basically, we found that patients who have severe calcium is the problem, not mild or moderate, which is the white or the red. So it is the severe calcium because associated with higher lesion, lower lesion success and higher subsequent MACE in terms of MI and TVR. So basically, we are still trying to work how to take care of the severely calcific lesions, and there are many studies which have been presented, one of them being the Euro 4C registry, using the rotational atherectomy in multiple centers, showing that yes, complications do occur in these cases, but overall remains in these calcific lesions less than 5% and good MACE rate. But many of these patients do have death non-cardiac and largely because of their high comorbid conditions. So we actually have published our algorithm that how to take care of this calcific lesion, and recently did about 1.5 years of hard work to get top interventionists who use rotational atherectomy and come up with the North American expert review of rotational atherectomy in circulation, and really emphasize various technical aspects, who should do it, should not do it, caution, complications, how to manage, very extensive our publication in this field. There is another publication came out of in the JACC about the calcific coronary artery, state-of-the-art review. One of the new device which is coming is the shock wave called lithoplasty or lithotripsy. Basically, just like you do a renal stones breakage, we are trying to break that calcium by a balloon and putting those ultrasonic energy and crack the calcium, and we'll be hearing more and more about this device. There is only one trial at present ongoing to answer the question whether atherectomy improves outcome on long term. That is the ECLIPSE trial of 1,800 to 2,000 patients, orbital atherectomy versus conventional balloon angioplasty followed by stenting, and see whether there is an improvement in overall outcome and decreased MACE at 1 year. Second, National Cardiogenic Shock Initiative. As you know, the shock is always a trouble. We know that very high mortality, about 70+%. Various trials have shown and failed of balloon pump, medical therapy, multiple. You have higher vasopressors, you have higher mortality of these cases. So therefore, actually, the Dr. Bill O'Neill from Detroit took this initiative of the cardiogenic shock. So what they did basically is came up with a clear-cut plan that how these patients should be managed with the well-defined protocol, and after the initial success, showing the survival in about 60, about 70+% of cases, started the National Shock Initiative program, which went to various states, including New York also, 76% shock initiative have started, and that has actually led to what used to be in their own 72% survival became 88% survival. They have clear guidelines how these patients should be managed, initially rapid transfer, right heart catheterization, use of Impella CP device, and of course very close monitoring. And when patients start going down, you escalate to LVAD and ECMO. So this, by all those, has really led to, now we can say, until now, we used to have 50% survival. That actually has improved to now 77% with this National Cardiogenic Shock Initiative. So which has led to making the shock care centers. So just like you have the stroke centers and MI centers, the shock centers, and there is a clear-cut pathway that how these centers should work with the EMS, with the ED, and going to the cardiac catheterization lab, and rapid escalation, not wait and watch. See what's going to happen to the patient. So once patients start deteriorating, that you're rapidly with going to the algorithms, and they have 7 points very nicely written. I won't bore you with that, but this is part of our QA initiative because we are starting at Sinai with the advanced mechanical circulatory support. So besides just doing the PCI, you need to give some additional support to the myocardium. Artery may be open, but because myocardium is damaged and stunned, you need to go to a next level of care besides just doing Impella. And as I mentioned, so very nicely now we call it a shock team and shock doc. So new specialty has originated with this. And I expect Mount Sinai being part with our such a big network, which we have started. We have the Mount Sinai MS Shock, the telephone call, and patients are being transferred, and we are evaluating where are the system gaps and how to follow what has been basically suggested in the literature. So we are following those, and hopefully in next 1 year we'll have our own data that what is our mortality of the cardiogenic shock patients. So really very important initiative now. Define PCI and imaging trials of PCI. There are two of them, which one was the defined PCI. That means that you have done a good PCI. We know that FFR and IFR are the physiological testings. If IFR, which is the resting indices, if it's less than 0.89 means there is significant lesion. If you have FFR, we give adenosine, less than 0.8 means significant lesion. If there are more than 0.8 on FFR, more than 0.89 or in IFR, that means it's not a significant lesion and those patients are treated medically. So understandable. But now you have done the PCI. What if your FFR or IFR still remain low? And we know that many of these patients after good PCI continues to have angina. We always say microvascular angina, stent stretch and so, but truly they have angina, and of course we know the MACE rate occurs as shown in various studies. So also studies have shown that you have done the PCI, you are done. Now if you measure the FFR and IFR in those, if you see some percent of cases is still less than 0.8. That means you should be doing PCI now while you are already completed. So same, the data on various, that once you optimize, you may get better. And of course, once you have a lower FFR and so, is associated with higher event rate at follow-up. So we want to get, so this is PCI done, FFR less than 0.8, of course there is a high event rate. So idea is, maybe on angiography, it looks good. Maybe we had not really complete ischemia. So this was the trial called defined PCI. Idea was, let's see what percent of patients where we had done the good angiographic PCI, that IFR is less than 0.89. That means significant, as if you have not done the PCI. So this was a very interesting study. And idea was to just go through blinded. Now, don't change the therapy yet. Just let's understand what the problem is. So therefore, 0.89, do the IFR, and you can see some percent of cases, IFR remain less than 0.89, even after successful PCI. So majority of them went up, but about 24% of patients, you're looking good otherwise, but mild diffuse disease, you combine, it will create a decreased flow in the distal vessel. So therefore, positive IFR, and shown that 24% of these patients will have, after successful PCI by the expert operator in the multi-center study, having an IFR of less than 0.89. So we are leaving 24% patients ischemic. No wonder why many times patients have chest pain and positive stress test even after good successful PCI. Now, many of those are with a focal lesion. Majority of them, there is a little focal lesion at the end, at the stent, the edge, or distally, and of course some cases have diffuse disease. So we know that diffuse disease is a trouble, you can take care of it. But at least focal, maybe optimize and put another stent. So diffuse, you don't want to do the full metal jacket of the vessel, but you can do. So this is what is proposed in the, basically what we should be doing in this randomized trial, which is just taking off, define guided physiological stenting. So not only that what you have done one is the IFR guided, you pull back, and then you do PCI based on it. Your additional stent needed to make IFR more than 0.9 and compare to your standard care, and you'll hear more about it in a couple of years to see whether IFR guided improves overall outcome. There is another trial that OCT, you look at the lesion by the IVUS or OCT, which is a little more sophisticated, versus you do FFR guided PCI. This was the Forza trial, and basically FFR assessment and OCT assessment of the patients who underwent PCI. And you can see sometimes concordance as well as discordance of lesions look good. And of course, we have clear-cut criteria that what should be have a PCI based on the OCT, that area stenosis of more than 75%, MLA of less than 2.5 millimeter square, and so. And basically found that once you do OCT versus FFR guided PCI, there was no difference in MACE, a small study, and no difference in angina status. Both were about the same, 6.8 to 8. But what happened is FFR guided PCI has a short length of stay and less expensive. Why? You put less stents. OCT, you put more stents. More additional devices to optimize. So clearly the FFR, now this is 1 month study. They're following these patients for 1 year and so. We'll know more MACE point of view, but it seems to be short-term MACE equal, but resource utilization are less. Actually, dye use also was less. Then the issue was the patients who are high risk for coronary artery disease, they have finished their acute event. MI is done, PCI is done. What happened 1 or 2 years later? Should we give them aspirin or aspirin clopidogrel? As you are aware of that Karishma trial done, didn't make any difference. Diabetic is a classical subgroup of our CAD patients. What if you had ticagrelor? Because there was a trial called Pegasus, which showed that patients who have a stent more than 1 year, those who have prior MI, if you continue the ticagrelor after 12 months to 30 months, you have better outcome. So question was, what if you do it in a diabetic patient, use the ticagrelor, and of course, many of these patients will have prior PCI. So that was the trial, THEMIS and THEMIS PCI. So this was presented, background basically, as I mentioned, and a large number of patients, 20,000 patients, and basically showed that in these diabetic patients, 20,000, that by giving the ticagrelor, which was 90 and then decreased to 60 milligram twice a day. So any patient who is stable CAD, for whatever reason you want to give, after 1 year, should not be 90 milligram twice a day. Ticagrelor dose should be 60 milligram twice a day, because that is associated with a lower bleeding without compromising efficacy. So basically what they found at 3-year follow-up, then there was about 0.7% lowering of death, MI, and stroke in these diabetic patients compared to placebo, which is okay. This was the individual endpoints, which you can see here, but the problem is here. By giving ticagrelor to these patients, compared to aspirin alone, you have a higher major bleeding, more than 1%. And remember, the ischemic endpoint was only 0.7% decrease. And now you have a higher bleeding, 1%, and including your major bleeding as well as intracranial hemorrhage, about 0.2%. So therefore, if you think about the net benefit, safety versus the efficacy, it looks like it's not safe. So editorial basically was that in diabetic patient with no stroke, no prior PCI or MI, giving routinely ticagrelor is not beneficial because of bleeding, and of course there was a lot of discontinuation of the drug. So what about the patients? So therefore that was the conclusion. But what about the patients who have a PCI? So that was the sub-study of the THEMIS, which is THEMIS PCI. So what about the patients who have PCI in the past? As you can see here, of those 20,000 patients in ticagrelor or placebo group, about 60% had the PCI in both. So what is this group who had a PCI before? Was there a benefit of ticagrelor in these patients? And answer to that is yes. So answer was that patients on the left side, as you can see, the benefit about 1.2% lower death, MI, and stroke in the patients who have prior PCI, but no difference in the patients who did not have PCI. So at least we will learn one. But then second is, what about the bleeding? That was the concern in the original trial. And you can see here, yes, bleeding still was slightly higher, but it now was no longer, these are the individual endpoints, but basically not the fatal bleeding. So major bleeding was about 0.9 higher, but the intracranial hemorrhage and fatal bleeding was not higher in the PCI subgroup. So basically they concluded the net clinical benefit still favors in a patients who have diabetes, prior PCI, that you continue ticagrelor for 3 years at a 60 milligram twice a day along with baby aspirin. And this was basically the overall, the events that benefited in this side, not on the prior PCI side. Whether it will change the practice or so, I'm not sure, but very positive, the conclusion of the trial was that ticagrelor in diabetic patient does work and may be used as a second line prevention of these events. So this adds to many other studies which have been done in the ticagrelor and this field. Now what also we learned, that anytime you have any agent, this antiplatelet agent cause bleeding, you need the antidote. And luckily, now we already have an antidote of ticagrelor, which have been done in the healthy people. And basically, that once you give ticagrelor, your inhibition aggregation is quite high. I mean, 20% goes down to 20%. But if you give this agent, rapidly reverses the ticagrelor effect. So very, very interesting, a small study, but published in NEJM, and hopefully we'll have soon the reversal agent for ticagrelor also. Then Augusto trial of NOAC versus warfarin plus minus aspirin. As you know, there are few trials have been done in the past, WOOST, Pioneer, and REDUAL. All those have evaluated combination of dual antiplatelet therapy or single antiplatelet therapy with the NOAC and so. And overall, I would say the answer basically was with the Pioneer AFib that you take a 15 milligram of rivaroxaban plus clopidogrel 75 milligram had the best risk profile in terms of efficacy and lower bleeding. But we needed to go a little further. So what happens? What about the aspirin? Do you really need it in a randomized fashion? And this was the trial, very nice trial, you can see here, of 4,600 patients. Answer was giving apixaban versus vitamin K patients who need the anticoagulants, and then whether they should get aspirin or no aspirin. So it was 2 by 2 factorial design, and of course it's a 5 milligram BID, but look at this, many patients, old age, less than 60 kilo, high creatinine, got 2.5 BID. And that is where, and then of course all these patients receive clopidogrel as the background in the 93% of these cases. So very important question. Is the warfarin better than, or apixaban better than warfarin? And secondly, what happens when you add or subtract aspirin with this? So this was the individual design, and you saw basically here now that vitamin K antagonist in terms of major bleeding and or clinically relevant non-major bleeding was significantly lower with apixaban compared to warfarin. So another study showing warfarin bye-bye. The apixaban was better. And these are clearly, now what about the aspirin? In those group entire, aspirin has a higher bleeding again compared to placebo. You say, well, not surprised, but clearly we learned again now that aspirin was the culprit. And then if you take all those 4 scenarios, and look at this, just 1 second to point that out, that if you have vitamin K, warfarin, aspirin, very bad. Worst. Apixaban, aspirin, second, then vitamin K plus placebo, and then lastly is apixaban and placebo has the best outcome in terms of bleeding, lowest bleeding, 7.3. So what should be our standard of treatment? Should be apixaban alone, along with single antiplatelet therapy of clopidogrel patients who need these therapies after whether intervention or management of acute coronary syndrome. And these are the individual endpoints which are shown here. Now if you take ACS medical patient, ACS PCI patient, elective PCI patient, the story remains the same, that apixaban is superior to vitamin K antagonist. And of course, if you add aspirin and take a 4 different subgroup, it remains aspirin plus apixaban plus placebo has the lowest bleeding and of course the lowest the death and hospitalization. So that becomes the standard of treatment now as of the latest trial. Now Safari STEMI, a trial of radial versus femoral access, what is it? So you know that over the years many trials have been done to see whether radial access is better or femoral access is better. Latest being, last year I presented one of our top advances, matrix trial of the 1-year follow-up comparing radial access in STEMI patients versus transfemoral, and basically showed that 1 year net adverse coronary events were lower with the radial compared to femoral. So clearly this added to many other trials in the past with the overall individual endpoints lower and lower bleeding became the guideline. We don't have guideline updated in the United States, but it's a class 1 indication as the European guideline of last year. We say, well, everything looks like yes. Answer is radial is the answer. Well, we always know in our field, nothing is long lasting. So much so, we get a trial. Safari STEMI, trial done from Canada in STEMI patients. Now these are basically, probably what the criticism always was, this radial fanatics, you know, those who consider themselves as a radial center. Maybe there you do the trial, the radial was better. What if you take in the entire country and see what happens? And this is what done in Canada. So lot good centers. So trial of the, again, large number of patients with the comparing radial access versus femoral access. And of course, you give heparin and the P2Y12 at your discretion. Avoid patients who have fibrinolytic therapy. As you can see here, the clopidogrel was given in 18%, ticagrelor in 90+% of cases. It's all PCI done with bivalirudin. And what did it? The radial caused delay in your PCI. You see that onset of balloon time, arrival to PCI center, and clearly it caused more fluoroscopy time, and so forth. So basically what it did, that even in the good centers, radial caused a little more delay compared to femoral. But what does it mean? Did it cause any problem in overall outcome? Well, it's basically first time now. The large trial of 2,400 patients showing that there is no difference in 30-day mortality. Now it wipes out the entire, our 7-8 years of publications. All kept on saying radial is better, radial is better, radial is better than femoral. And so that everybody had to learn radial. You know, sometimes we say that you can't teach the old dog the new tricks, but we all had to learn. We started learning radial. Now all of a sudden, one trial says that no. And these are the individual endpoint of reinfarction, stroke, and more important, until now, and of course stent thrombosis was not different. More important, biggest advantage of the radial was lower bleeding and vascular complication. And look at it here. In these patients, no difference. So that basically means you're a good operator, you have good access, femoral closure, clearly as good as the radial, so you don't have to feel bad about it. And this adds to numerous trials, which I mentioned, and the saying that Safari STEMI is the largest study after Matrix and the largest dedicated primary PCI study, and showed basically no benefit of radial intervention. So that whatever you need to do, that's okay. Don't have to feel bad about that if you don't want to do a radial intervention in acute MI, although the whole country is right now going on the radial bandwagon. We may need 1 or 2 more trials to really, I would say, balance out this field. Then, what about the long-term follow-up of the patients with the PCI in CABG? Remember, you have heard about 1-year follow-up, 3-year follow-up, 5-year follow-up of the PCI versus CABG. Usually they are done for left main or multi-vessel CAD. What we know so far, the CABG, lower repeat revascularization, durable angina relief, lower mortality in high syntax score or multi-vessel diabetic like Freedom and Syntax trial, better quality of life parameters. The PCI, rapid recovery, lower length of stay, better short-term results, lower CVA, improvement in EF, and similar outcome in left main and low syntax score patients. So these are the data we have up to 5 years. Now what happens between 5 to 10 years? Even if some studies, which is the CABG, showed the benefit, we are hoping that maybe after 5 years, the graft will start closing. So PCI stent, if it doesn't give trouble after 1 year, will be good. So that is what the hope was. I can tell you in 2019, let's see, our hope was maintained or was shattered. We have the trials of the various follow-up. As you can see here, 5 of them presented 5-year plus data of this. One was the Lehman's trial, very small trial. It did show they were beneficial even at 1 year, 5 year, 10 year, that better ejection fraction. But this was a trial done in Brazil, not a good results because only Lima was used in 72% of cases, but at least one positive trial. Second, Freedom follow-on study, which was just published in JACC, which was the extension of the original Freedom trial, and basically following these patients for about 8.5 years, showing still the mortality in favor of CABG over PCI. These are the diabetic patients. Clearly, the higher mortality of the PCI, we knew at 5 years, and now at 8.5 years, curves actually slightly separated more than what it was there originally. And if you take the whole Freedom cohort, and particularly younger the patient, better was the benefit. So seems to be that diabetic patient, multivessel diabetic, young age will benefit on long term, 8.5, 10 plus years with the CABG. Then the Syntax trial, which was the data of the 5 years which was presented before, based on the Syntax score, CABG versus PCI, we knew that overall the 5-year, the MECI, which is the adverse cardiac and cerebrovascular event, was in favor of CABG, particularly so patients who have more complex disease. Now we have the 10-year follow-up of those called Syntaxes. Syntax extended survival endpoint, and we showed the 10-year all-cause mortality, again about 4% statistically just in favor did not make a p-value significant, but again, the curves will start separating. And if you take multivessel disease, it all become positive. So multivessel patients, high complex three-vessel disease, they did better with the CABG compared to PCI. Left main did not. And if you take here, based on the syntax score, and syntax score is more than 33. This is the third group that clearly the higher is the syntax score, patient will do better with the CABG. But again, this was the trial done with the old stent, Cypher and Texas, but this is what the data we have. There was another one, main compare, more of a registry data, showed the similar data, but more important, I want to bring you to the attention, is our Excel trial. Excel trial was the trial of the left main with intermediate syntax score, 32 or below, randomizing them to the current drug-eluting stent versus CABG. And this was the trial of 1,800 patients, and basically we knew that at 3 years, they were identical. This was the data presented about 2 years ago. 3 year, identical. We all learned that after 3 years in the Freedom, Syntax, in Barry, the curve separated only after 3 years. And you see here, overall endpoints point of view, death and stroke or MI at 5 years was identical, but problem, same. Mortality. Even in these patients with the intermediate syntax score and left main, there was about 3+% mortality benefit of CABG compared to PCI. So it shows basically that although overall endpoints were not significant, but the stroke was higher in the CABG group, which we always expected, but of the revascularization, and so was higher with the PCI group. But more importantly is the mortality. That is a concerning, and even with the current stent, overall, although the trial, the data looks very positive, but to me, I think we have to be honest, that truly patients with the long-term, we are looking into it, even PCI in an intermediate risk left main group did not stand against the CABG. So then, the few other, quickly, the complete trial of STEMI PCI, this has been a debate, culprit versus complete revascularization in STEMI. We had done 3 trials of PREMI, culprit, and Primluti, and all those showed that doing a complete revascularization in STEMI patients was superior and having a lower subsequent endpoints compared to just doing the culprit vessel, and that changed the guideline. It used to be 3, became 2B. So recommendation changed in 2013 because of the various trials. So now question was, these were the small trials. What about the large trial and with a different strategy? And basically was that if you do a complete revascularization, should you do it in hospital or you do it after discharge? And the large number of patients, this was the complete trial primary objective. Again, 4,000 plus cases. These are the individual, the baseline characteristics and the procedure done, the radial approach, and so not a very complex, but it showed that death and MI, it was 2.7% in the complete revascularization at 5 years compared to 3.7% in the culprit only. So clearly the culprit, it seems to be the complete revascularization in STEMI patient is the answer. And if you take a ischemic revascularization, curves are even further different. So these are the individual endpoints. There's no difference in death, but definitely the MI and ischemic revascularization is better with the complete revascularization. Another major trial we showed. Now, second issue was, should you do a PCI in the same hospital admission if you decided for complete revascularization, or you should do it after initial hospitalization? It turns out to be that whether you do it same hospitalization or within 21 days. They did it within 21 days, there was no difference. So these are the individual endpoints of so it basically puts it together that another evidence that you should do complete revascularization. Now, it's a little different in the culprit shock. The shock trial, when you complete revascularization, a study showed that complete revascularization had a higher event rate compared to only culprit vessel revascularization. So it's a totally different strategy in the STEMI patients compared to culprit shock. And that changed the guidelines that now the full revascularization in a cardiogenic shock patient is not indicated. It's like class 3. You should do only the culprit vessel PCI. Now, based on the positive data of the complete trial, are we going to change the guideline from 2016, which is, or 13 to 16, which is 2A, to a 1B? And just time will tell, but it seems to be there's enough evidence now that complete revascularization is better. Then the ISAR REACT 5 trial of comparing prasugrel versus ticagrelor. You say, what is this all about? Well, we had done the trials comparing to P2Y12 inhibitor. We did Triton TIMI trial comparing clopidogrel and prasugrel, where it showed benefit in the ischemic endpoint but higher bleeding. Then we did a Plato trial, clopidogrel versus ticagrelor, and it showed that better in terms of ischemic but higher bleeding rate. So clearly we have the data that these agents were better than clopidogrel. So now what about that led to the guidelines, and they are the preferred agent in your STEMI and non-STEMI patients. So what about comparison of the ticagrelor with prasugrel? We have one small study of the STEMI patients, about 1,200, showed the no difference in outcome. But this was still the small study. So then now we have the major trial of 4,000 plus patients in acute coronary syndrome comparing ticagrelor versus prasugrel. This was ISAR REACT 5 trial. So basically, as you can see here, non-STEMI were 46%, STEMI were 41%, unstable angina 12%, 2,000 in each group, ticagrelor versus prasugrel. And what did they find? To lot of people surprised, but I can tell you, it has been my practice many times using the prasugrel, because in last few years, people stopped believing in prasugrel. Now we have this trial, ISAR REACT 5, showing head-to-head comparison with ticagrelor that prasugrel was superior in terms of decreasing the MI, as you can see here, compared to primary and compared to ticagrelor, and that basically drove the positive endpoints in favor of prasugrel. Now, what about the bleeding? As you can see, bleeding was no difference. Why? Because prasugrel always used to have high bleeding. Well, they used a 5 milligram dose in many of them. And if you know, at Mount Sinai policy is, we give 5 milligram, 10 milligram only to patients where we have put more than 3 stents or patient more than 100 kilo. Otherwise, everybody gets 5 milligram in our cath lab. And I think that is what, in my opinion, the lower bleeding led to the better outcome as shown here in this ISAR REACT 5 trial. Very, very provocative trial. Second trial was, what about the old patient? Should you be using ticagrelor versus or clopidogrel versus prasugrel? Old patients, clopidogrel versus ticagrelor, and showed again that bleeding higher with ticagrelor in these patients, but no difference in ischemic endpoint. So it makes sense. Another group of patients, old patients, don't give these agents, a strong agent which cause more bleeding. Clopidogrel does quite a good job. The top advance, in my opinion, the trial of coronary intervention of 2019 is the twilight trial of aspirin discontinuation. Aspirin has become the bad child in some way in this entire year. So until now, we know that ischemic, you need the dual antiplatelet therapy for 3 to 6 months. 12 months you definitely need for ischemic. And we have done the trial to stopping the P2Y12 inhibitors. But it turns out to be, what if the aspirin is the culprit? Because maybe it's not the P2Y12, it's the aspirin which is the trouble. That is causing the bleeding, and we know aspirin, a lot of people develop bleeding. So this is the year of, I would say the last year, many of the primary prevention trials of the aspirin really showed the aspirin was not beneficial or even harmful. Then it went to the intervention. One of the trial basically was the global leaders, which showed overall that there was no benefit, there was just a slight benefit of discontinuing aspirin after 1 month compared to your regular routine therapy. So at least give idea that 1 month, there was a lot of compliance issues, so that overall, although trend was there, but did not make a superiority with the 1 month of aspirin discontinuation. And then we did many of the stent trials where we continue PTY12, but then stop the aspirin either at 3 months or 1 month. So this is the case, the trial where was done a smart choice in Germany, showing that by stopping your aspirin after 3 months, rather than continuing, that you have identical MACE and lower bleeding. Then there was second trial from Japan, stop DAP2. Another trial, stop aspirin after 1 month. and showed what? With a clopidogrel, that 60% was clopidogrel, 40% was prasugrel, and again, showing the same, that you have an overall net clinical benefit in favor of giving 1 month of aspirin and stop the aspirin after 1 month and continue the dual of the P2Y12 inhibitor. These are the individual endpoints. So it seems to be aspirin became the now, like nobody should take it. So the very nice editorial was, the dual antiplatelet therapy, is it time to cut the cord with aspirin? And answer that time was, maybe not that early. Let's wait one trial which they mentioned, and that trial was Twilight. And this is what presented by Roxana Mehran. Trial was done by our concept at Mount Sinai, was run by Mount Sinai Icahn School of Medicine, and the whole trial was implemented and published in NEJM last week. The hypothesis was, if you stop aspirin after 3 months, what happened is it was sponsored by AstraZeneca. I suggested to Dr. Mehran that make it 1 month, because we knew in our practice, we knew 1 month is good enough. And then, of course, the data came later on. I'm talking about back in 2011, 2012, when the trial was being started and formulated. But they did not agree. They made 3 months. And the plan was, the objective of the trial was that impact of the single antiplatelet therapy of ticagrelor versus DAPT. Ticagrelor plus aspirin for 12 months will have a lower bleeding, and of course, similar in terms of ischemic endpoint. Then we wanted to make sure that we are using it in a complex cases. So it was a high-risk patients, and they were defined, has to have clinical criteria of old age, female gender, troponin positive MI, and so. And then angiographic criteria, that is not a simple straightforward lesion. Multivessel disease, multiple stents, thrombotic lesion, bifurcation lesions, and so. And this was the randomization, that 3 months, all patients got aspirin and ticagrelor. After 3 months, in a double-blind placebo fashion, aspirin was stopped, and was placebo versus aspirin, then followed for 12-month additional, and then 3 months after that as an observation period. Multi-center, 180 sites, 11 countries, total patients started with 9,000. The 3 months event happened in about 17% of cases. So of the 9,000 became 7119 patients which were randomized to ticagrelor plus aspirin 3564 and ticagrelor alone 3555. And these are the individual, the procedural details and so. And most important is our primary endpoint was the bleeding, and expecting or predicting that ticagrelor alone compared to aspirin after 3 months will have a lower bleeding. And guess what happened? Absolutely correct. That was a 3% lower bleeding with ticagrelor alone after 3 months and continue another 12 months. You say, well, that's okay. But what about aspirin? Maybe it causes thrombosis. These are the individual endpoints of the bleeding. As you can see, the lower bleeding in all the subgroups. But then the efficacy endpoint, which is the death, MI, and stroke, which were concerned by dropping the aspirin, what will happen? Well, nothing will happen. Exactly identical. So clearly has paved the guideline change that aspirin probably should be given between 1 to 3 months once you're using a ticagrelor therapy. These are the ischemic endpoints, and so also it actually they showed the benefit in both acute coronary syndrome as well as stable syndrome. Acute coronary syndrome was 65% of the patient population, and so. So this was, then question was, why that happened? Is it by taking aspirin? Did you decrease the platelet activity? This was a sub-study of the Twilight, really looking into the mechanistic region, that is this, does the effect of ticagrelor correlate with the platelet activation? It's a Badimann's chamber, a lot of thrombogenicity, platelet activation studies were done, and basically showed that your ticagrelor plus aspirin or ticagrelor plus placebo had a similar platelet inhibition. So what does that mean? Aspirin did nothing except causing bleeding. Nothing in the ischemic, nothing with the platelet aggregation does cause bleeding. So and these are the, for also different platelet reactivity. So now we have the basis of the outcome of the Twilight trial with the understanding this feature. So therefore, ticagrelor with or without aspirin in high-risk patient, Although high-risk patients who underwent PCI and completed 3 months of dual antiplatelet therapy, ticagrelor monotherapy was associated with a lower incidence of clinically relevant bleeding than ticagrelor plus aspirin, with no higher risk of death, MI, stroke, or stent thrombosis. So this, in my opinion, is the top trial of the coronary intervention in 2019. So now put it together. So what did we learn today? Change in clinical practice for the trials. We saw radial PCI in STEMI, ticagrelor in diabetic patient. No good. CABG 5 to 10 years plus. Rotational atherectomy calcific lesion, FFR PCI, clopidogrel in 70 years of age, 1 plus. Multivessel STEMI PCI, cardiogenic shock initiative, NOAX alone without aspirin, plus plus. The real plus plus is prasugrelin ACS and aspirin 1 to 3 months post PCI with ticagrelor, to me a real game changer of 2019, to us become a better interventionist and improve our patient's survival. With that note, you know that our data of the 2016, we have the last, our PCI report, while maintaining the big lead than any other center. Double star means the statistically lower mortality, 30-day risk-adjusted mortality, and this star we have since the report comes in 1994. And many of our interventionalists, myself, Kini, and others, this year actually was Pedro Moreno, and so I get the double star because having a 30-day risk-adjusted mortality lower, the growth continued. So PCI, when we felt that it was going down, now appropriate cases are coming up, and overall complications, if this is the data for last 5 years, less than 1%. Major complication of death, MI, taken all patients together, and stroke remain. And of course, the mortality of the PCI is about 0.3 to 2.3%. So really has made a big difference. Dr. Kini already shared our CCC live cases, which we have both, all three actually, coronary, peripheral interventions, and structural heart. The first one, the third Tuesday, is the one which we had done for 10 plus years, just celebrated. And now the live pages, we have our own CCC live webcast of 764, and then we have YouTube. So over 1 million. 1 million hits to our monthly live cases for last 10 years in 130 plus countries. The top being USA, second India. India is a big follower along with many, many other countries, because goal is always to disseminate the knowledge, get the best results, get the best strategy, not only procedural, also pharmacology and the subsequent treatment of these patients. Just to advance this field further, we started last year, did the first time, the Transcatheter, New York Transcatheter valve. This year is on December 5th, will be in New York, and in Grand Hyatt, this one-day dedicated conference for the structural heart. We'll do about 6-7 live cases. I have great faculty just finishing the program, but there will be another resource, educational resource available for all of you to be part. With that note, I'll stop here, and thank you very much, and I'll take any questions. Yes. Yeah, that's another point. So the dose now comes down to, so of the various agents, clopidogrel, ticagrelor, and rivaroxaban has shown the 2.5 milligram twice a day. Patients with coronary artery disease or peripheral arterial disease have benefit, but same, has associated higher bleeding. So key is, so people have not shifted to it. So, but that's another agent in a stable patient who have history of CAD, peripheral arterial disease, along with aspirin. I would say the answer would be the day we do another trial with agent alone. If you would have used rivaroxaban 2.5 twice a day without aspirin, I'm sure benefit without having the bleeding. But still, there is a bleeding issue. So question will come now that what do? You have the ticagrelor based on the Pegasus trial, that patients who have prior MI, so you should continue. Patients we have with rivaroxaban 2.5 twice a day, another agent, and now diabetic who have prior PCI. So should you be using ticagrelor? So I think this is the field evolving. To me, our concern should be now, not ischemic. Our concern is the bleeding. And because stents are the management of the patient, medical management, and the PCI point of view have become so good. So we are not worried about ischemic. We are worried about bleeding. So anything which adds to bleeding is a problem. So now, if you think about the first time of the trial done, Twilight, we took something out rather than adding. Every trial added some agent. We said, no, take that out, take the aspirin out. So I think this will be maybe a major player. After some time, maybe just giving a ticagrelor alone without any aspirin. So I think many other trials are being formulated at this time. But my message is very simple, that patients who had finished their duration of, let's say, 1 year of antiplatelet therapy, so which patient you should continue, whether rivaroxaban, ticagrelor, or clopidogrel in some cases, because even Karishma, in the Karishma trial, the patients who have prior CAD was a benefit. So any of these agents, maybe those who are frequent flyer, frequent events, may continue, and you decide one of the agent. But unofficially, I can say, once you decide that, probably it's prudent, based on the data, although no trial has done yet, that take away the aspirin. The only trial, both the global leaders and Twilight, is the trial of PCI patients. So we took the aspirin out in the PCI. We have not taken the aspirin out in the non-PCI patients yet. So that will be the next field to show continued efficacy of this more potent agent, but without affecting, without increasing the bleeding. Okay, any other question? Yes.
Aspirin now that we have so many other options, low dose, ticagrelor, low dose Xarelto, so on. What is the future of aspirin?
So I think till we know some definite trial, but it looks like that our love to aspirin has to go away. This was the agent which everybody felt, even the people with the middle age with a little risk factor, diabetics, taking aspirin, the trial showed no benefit, rather create more trouble, bleedings, maybe even some cancers and so. So key is that aspirin is going out now. So what question is, what would you do now based on the data we have at present? So I would say that it's reasonable at present from PCI point of view that you give it for 1 month only, which is between global leaders and Twilight, 1 to 3 months, whichever way, but then continue one agent. Now what about if you're giving a clopidogrel and you're taking the aspirin out? Well, with the PCI we learned, with the both smart choice and stop DAPT, that 1 to 3 months is also enough. So key is, the PCI seems to be okay, that you take the aspirin out. Now question is, when you're using other agents, what would you do? So one thing for sure, that once you're using the NOACs for some kind of secondary prevention, it looks like that alone is good enough. So like Augustus trial. So similarly with rivaroxaban. So those that it's okay to just use alone without aspirin. So key is for PCI, just give it a very short time. Outside the PCI, probably these agents alone will be good enough. So that will be my message, and that is what I would say I will recommend in our as a protocol and the guidelines to our health system. Yes.
Yeah, so beyond 12 months, we don't know yet. That's number one. Number two, there are a lot of people who cannot tolerate Brilinta because of respiratory problems and so on. That's number two. The third one is surgery, pre-op evaluation, pre-op clearances that we have to give for non-cardiac surgery. These days we say if it's aspirin, we continue. So those will be issues that then you would.
Yeah, so the question will come that what about you do more than 12 months and so. So I think in the Twilight we did 3 months after when we stopped the ticagrelor and we left whatever people wanted to do. And majority of them, they stopped the ticagrelor, continued only aspirin, there was no rebound effect. So question will come more complex will be that these patients now, while those who need non-cardiac surgery, we always have allowed now except for the spine or neurosurgical procedure that continue the aspirin and stop the P2Y12. So now question will come, if you are only on P2Y12 inhibitor, only, and no aspirin, So now you are going for gallbladder surgery or hip surgery for 5 days discontinuation, which is for clopidogrel, and 7 for ticagrelor, and 7 days for prasugrel. What will happen? So that is again some issues what should those patients go back on aspirin for their non-cardiac surgery? We know that for neurosurgery, no, but non-cardiac surgery. So I would say I don't have a clear-cut answer for that, but I would say that if you've gone beyond 1 year, probably brief interruption will be okay, because that we learned from the Paris trial. So brief interruption, particularly once you have gone beyond a certain time, 90 days, 180 days, and so brief interruption doesn't give trouble. And knowing that patient didn't have any event in between that time before. So that brief interruption of 5-7 days will not be a trouble. But yes, this will be this is the question which probably some further studies or publications will answer that question, that maybe should that patient get some antiplatelet protection, because now the patients were on ticagrelor, patients were on rivaroxaban or apixaban. So what you do in those cases? Should you change for that time period on aspirin? We don't have the answer. But that, yes, that will be a problem, but hopefully will be the good problem, because other patients will do very well without having aspirin and less bleeding. Yes. 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 So basically we actually adopted the policy. We did a small trial with the platelet activation and reactivity at our center. And what we found that on top of aspirin, everybody got baby aspirin, that giving 10 milligram was too much. It was inhibiting platelets 90%, 98%, and which we call PRU, platelet reactive unit, was like 40, 50, which should be about 200. So therefore, we did the study to see what is whether 5 milligram is good enough. And we found that 5 milligram of prasugrel was good enough, but loading dose the same. Is a 60 milligram, you load patients who are naive, and you give 30 milligram loading dose patients who are already taking clopidogrel. So with that load, you're taking a 5 milligram, where we found the trouble was if you're 100 kilo and above, or you put multiple stents, because those are not even diabetics. Those were the state more platelet aggregation or maybe higher dose was required. So that we made the policy almost 5 years ago, that anybody at Sinai, and I know that many of our referring physicians question that policy, and so, but I can tell you, we follow our patients and we have never been in trouble, because it's the higher dose which causes the bleeding, and therefore low dose of 5 milligram is very efficacious and it's good enough. So rare patient, or not rare actually, 100 kilo is not rare nowadays in America, but 100 kilo and above and more than 3 stents, that patient should need a 10 milligram. Or if you know the known resistance. Now, if many times we do the platelet reactivity test, we used to do it very commonly, but studies showed that incorporating platelet reactivity in your PCI doesn't matter, because those did not change by increasing the dose or so. So if we have ever done, we do now maybe 1 or 2 patients every other day, if we found the platelet, the unresponsiveness to clopidogrel, in that case, and I have to use the prasugrel, there I will use the same 10 milligram dose. But otherwise, 5 milligram in all, except 100 kilo and more than 3 stents. Okay, so now we have time for the iPad Pro to have a different owner. And let's see who it will be. Kim, you want to come and help me out here? So you have to see the last 3 numbers which Kim is going to say. You take it out.
$506. 506.
Oh, already there?
Yeah,
Okay.
All right.
All right. This is so rare that you get this in the first shot. All right, so we thank everyone for a great, hopefully it was very educational session, and good luck, and see you next year for this symposium, although there will be many more from ours. Thank you very much. All right, very good.